we are live.
Hi, good evening. Good evening, everybody. So this is the sixth symposium or sixth webinar or virtual meeting by Noida Ophthalmological Society, and we are very fortunate to have Dr. Rajiv Raman, who is from Shankar Netralaya, would be talking on artificial intelligence. We will also be joined by Dr. Dinesh Talwar. He is right now just finishing off his surgery, so he'll be joining very soon. And then with me is Dr. Shahana Majumdar, Senior Consultant at Eye Care Hospital, Dr. Anupma Upasni, who is the moderator, who was the earlier Secretary of Noida Ophthalmological Society. And then we have Dr. Anshu Arora, who is again the moderator. He should be joining us very soon. We then have plenty of luminary speakers with us. We have Dr. S.P. Chaudhary, Dr. Anubhav Goyal, Dr. Ruchir Tiwari, Dr. Anmol. Why you labeled it as Anmol Ahuja? Dr. Priyanka Khandelwal. I just said it as Anmol Ahuja. So you should change that. And then we'll be joining with Dr. Ankur. So I would now pass on Dr. Jawaharlal Goyal, our president, would be soon joining us. So I would request Dr. Anupma to introduce our keynote address speaker, Dr. Rajiv Raman, and Rajiv has promised to stay with us throughout this meeting till 9 o'clock. And I'm really, thank you, Rajiv. So let me tell you, I just say one word that I have known Rajiv for years together now. And whenever I have any problem, I fall back on Rajiv. He's a fantastic friend. He finds solution for all my problems, and he is a great academician. I will not take away anything from Dr. Anupma. Please go ahead, Dr. Anupma. Please introduce that. Thank you.
Good evening, friends. Welcome you all to the Diabetic Retinopathy update of Noida Ophthalmological Society. And our first speaker is Dr. Rajiv Raman. I would give a brief introduction. He is a senior consultant with Sri Bhagwan Mahavir Vitreoretinal Services, Shankara Netralaya, Chennai. He is also a visiting professor at Anglia Ruskin University, Cambridge. He has worked with NTR University of Health Sciences, Vijayawada. He was also the medical director of Choitram Netralaya, Indore. He has many scientific collaborations with Chinese University, Hong Kong, Singapore Eye Research Institute, Singapore, Madras Diabetes Research Foundation, Chennai, with IIT Chennai, Vellore Institute of Technology, Chennai, and Moorfields Eye Hospital, London. He has several awards and gold medals to his credit. He has several presentations and publications at national and international level to his credit. And I would welcome Dr. Rajiv Raman. He will be talking about how will AI help us manage diabetic retinopathy better. Dr. Rajiv Raman, please.
Thanks, Anupma, because if you had introduced Rajiv completely, I think 1 hour should be over.
Yeah, that's why
Thanks, Dr. Anupama.
And we welcome Dr. Jawaharlal Goyal, also our president, his incoming president soon, and Dr. Atul Singh, our president, should be joining us soon. Yes, Rajiv, please.
Thank you.
My slides are visible?
Yes.
Thanks, Dr. Ajay. Thanks, the Noida Ophthalmic Society, for giving me this opportunity to share with you some of my thoughts on how will AI help us manage diabetic retinopathy better. So broadly, if you look at what AI can do, one is it automates the repetitive task, the things which we can do ourselves, but to make good use of our time, or we don't have so many of us. Like example, if I want to screen all diabetics across the country, the number of people or number of screeners, if you look at, is very limited. Probably there, it is one of the tasks which AI can do. But more importantly, it can also try to find new signals, things which we cannot do, because it has a power of prediction. It can try to predict the things which our human eye cannot see. I'll be sharing how these can be useful, both of them, as far as diabetic retinopathy is concerned. So like automating a repetitive task is like screening for diabetic retinopathy, diagnosing various stages of diabetic retinopathy, classifying a OCT abnormality, whether it is a center involving or a non-center involving, or whether there is any DME present or not. So these are the tasks which AI can do and has been used to do in diabetic retinopathy. The new signals or predictions, so can it predict OCT thickness from the retinal photographs? Can AI predict the progression of diabetic retinopathy? Can it predict other microangiopathies, looking at retinal image, whether there is presence of nephropathy, neuropathy, etc.? Can we predict some response of therapy by anti-VEGF or steroid by using AI and getting some signals from the OCT, or probably adding a metadata, systemic data along with OCT? Can it predict other systemic abnormalities? So these are the few new things which are more like prediction, which we cannot see. Just seeing a retinal image or a OCT, we cannot actually answer any one of them. But can AI do that? And these are the ones which people have explored, and there are some ray of hope in these predictions too. So let's look into screening and diagnosing diabetic retinopathy. So what do the various screening guidelines say about using AI? And 2020, the American Diabetic Association, they included AI for diabetic retinopathy as a standard of care. They come out with this standard of care for diabetes every year. And in 2020, they included AI as a screening method. So they said that it can detect more than mild DR and diabetic macular edema. And they said, use something which is FDA approved, and it can be an alternative to a traditional screening approach. However, they went ahead saying that the benefit and optimal utilization of this screening is yet to be determined. And they also said that whatever the findings of this AI examination or whatever the findings are there, that should be transmitted to a healthcare professional so that to close the loop. So when not to use AI for diabetic retinopathy? One, if a patient is already having retinopathy, this is not something, so follow-up of a patient who has diabetic retinopathy, today AI is not the tool. So ADA doesn't recommend these patients should be subjected to AI testing. They should be seen by person by ophthalmologist. Or if patient is already on prior diabetic retinopathy treatment, or if there are symptoms of visual impairment. So basically what they came out with, that asymptomatic people who are diabetic, who don't have retinopathy, these are the ones where screening AI can be used instead of a traditional screening. What the AIOS guidelines suggest, that because in India, we don't have a real legal framework for using AI for DR screening, this is what the consensus guideline was, that it's empirical that the ophthalmologist should grade whatever the AI says as referable, and even 10% of normal, which AI has told it is normal, should be regraded by an ophthalmologist. Are these AI algorithms accurate, or how accurate these are? So this was way back in 2016, our first paper on AI, which really gained a lot of popularity. And after that, you got a lot of other papers coming on talking about using deep learning algorithm for DR detection. And indeed, last year, this was declared as one of the top 10 article of the decade by JAMA. So this showed that the diagnosis by a AI or a deep learning algorithm was in par with the ophthalmologist giving a diagnosis. And later on, we regraded it by retina specialists, and also came that it is similar to a grading which is given by a retina specialist. And thereafter, there have been a lot of these publications, lot of AI algorithms which have been developed across from 2016 till now. And the good thing is, accuracies of most of them are reasonably good. They talk about accuracy levels more than 95%, good sensitivity, good specificity to detect a sight-threatening diabetic retinopathy. That means we have many things to select and what to look for when you are selecting an algorithm. One is you should look at what was that training set like, how many number of images were used for training that. Because in our paper, we did show that after a certain level, like after 60,000 images, the algorithm performance didn't improve further. That means if you are using less number of images for training, not sure how good the algorithm would be. More important is how the ground truth was ascertained, because it's something like garbage in and garbage out. So if the ground truth for labeling of these data was not correctly done, we do anticipate that the algorithm will not be as good in picking up the lesions. Whether the algorithm was trained on a mydriatic image or a non-mydriatic image, because many times for screening, people use a non-mydriatic camera. And many of these algorithms, they have been developed by using a mydriatic image. So again, the performance will not be what has been described or what you are seeing the good accuracy. Whether the algorithm was trained on a single field versus multiple fields. So these are all very important, and selecting the algorithm will depend on circumstances of intended screening. So if you are planning to use a single field, non-mydriatic camera, you would tend to use an algorithm which has been trained or which was developed using these type of images. This was one of the work which we did it in Thailand. This was actually multiple cameras. So we wanted to know whether the performance of algorithm is dependent on the camera resolution. So this was about 8 cameras which we of varying resolutions, and you can see the ROCs for detecting sight-threatening diabetic retinopathy by a human grader, and you can see AI all towards the left up. That means they are pretty good. So these were gradable images. So if an image is gradable by human, definitely as far as performance of AI algorithm, there is no difference between the cameras. However, if it is a non-gradable image, which is very much true with a low resolution camera, the performance of the human and grader both show a lot of variation. So the conclusion is, if it's a gradable image, whatever camera you use, the AI algorithm performs similar. So there have been a lot of these modifications to improve the efficiency of algorithms for DR screening. This was one of our work which we did across, so nearly about 1 lakh images across the country from 20 sites. This is non-mydriatic retinal image through a handheld camera. And we tried looking at, can we create a deep learning algorithm which could identify whether an image is gradable or not, and give a prompt to the photographer that if it is non-gradable, he can retake the images again till he gets a little bit gradable. If there is significant media opacity, definitely still he may not be able to do, but just to improve that, and we could get a very good AUCs to determine whether the image is gradable or not gradable. This was another work which we had done with a group in Hong Kong. We tried looking at, can we develop an AI algorithm to detect the grading for a wide field image, ultra wide field SLO image. This was an optos image. And we could find reasonable good accuracies in diagnosing various stages of DR using this algorithm. And what you see in the right side are those heat maps, which suggest that what the algorithm looked into to diagnose the various the sight-threatening diabetic retinopathy. So now we have many of these algorithms which can be used for DR screening, both with a non-mydriatic camera, with a mydriatic 45-degree, with a wide field imaging. All these are pretty good, but how we implement it is a big question now. And how people have tried implementing it, either using it as an assistive mode, meaning the way we use it at Shankar Netralaya is people who are anterior segment surgeons who are not very much used to grading diabetic retinopathy. They know about it, but they are not very much upgraded on that. So the AI grading is shown to them once they do their grading, and then they are given a chance to modify it. So it's more an assistive tool. for a physician who doesn't know anything, it's a completely automatic mode. The images are given and the diagnosis is given. So it can be used as a fully automatic or an assistive mode. This is a short video which shows how it is integrated with our EMR and how we do the screening. So patient comes to an optometrist, a consent is taken, and the fundus photographs are uploaded by the optometrist. They also have a chance to write whether it was dilated or it was not dilated, whether the cataract was present or not. Then he goes to the ophthalmologist, anterior segment doctor, and he sees the images. He gets a chance to grade retinopathy, and then he views the automated result. If it is same, he can continue. If it is different, he has a chance to again review whether he wants to keep AI diagnosis or keep his diagnosis. So it more acts as a teaching tool for them. So these are the initial about 100 patients data. So you can see what we showed in our studies, even in real time, the performance, the sensitivity, specificity in detecting diabetic retinopathy was pretty good. And even for sight-threatening diabetic retinopathy, you can see the sensitivity, specificity pretty good. This is in the anterior segment clinic. Another way potentially which it can be used, one of the ways, so we have the fully automated, it can be used as a assistive mode. And this was one of the ways which we tried using it to reduce the referral. This was another algorithm which was developed from Korea, and it could grade any retinal condition, whether retinal disease is present or it's a normal retina, and could also diagnose the disc changes, whether glaucomatous changes in the disc versus normal. And the ground truth which was given for this was for retinal diseases by the retina specialist and for the glaucoma by the glaucoma specialist. And we tried using it that when we keep this in the glaucoma clinic, how accurately the algorithm could detect the retina problem, and we could reduce the referrals. It was only those where they were sure the algorithm suggested that there is a retina problem, it was referred. And we could find that it could really reduce the referrals if we use it in this way. We also tried implementing it in a nationwide screening program in Thailand, because Thailand is a country which has one of their targets is, one of the national goal is to screen at least 10% of the people for diabetic retinopathy, diabetics every year. So they have a good system in place, more than 600 cameras. So we could implement it nationwide, and we compared it with the human grader. And we found that definitely it reduces the false negative rates nearly by 23%, and on the cost of little bit increase in the false positive rates by 2%. So we concluded it may serve as a valuable tool for diabetic retinopathy screening. So now you must have understood, just like retinal images, even it can easily classify OCT abnormalities. And this is one of the algorithm developed by the Singapore team, which could detect whether there is a non-center involving or a center involving diabetic macular edema across multiple platforms, Cirrus, Spectralis, Triton. With a reasonable good accuracy, it could suggest that there is presence of center involving macular edema, again adding to the screening part. Now let's talk about the predictions, which we cannot do. So many times we do see that on a color fundus photograph, we see a center involving diabetic macular edema. When you do a OCT, the central subfield thickness is very less, edema is mainly paracentral. Or a reverse case where retina seems to look pretty normal, and on clinical imaging, very difficult to predict on a non-stereoscopic image that there is center involving DME. You do a OCT and you see these center involving diabetic macular edema. So this was one of the work which we did, a multicentric study where we labeled the fundus photograph with the OCT features and then trained the algorithm so that just by looking at fundus photos, can it predict DME? And it was pretty accurate. You can see the AUC of nearly 0.9. So you can see these are some of the case examples. Especially you can see the second one where on fundus photography, it was not, if you just use a retinal image, it would not have detected as CIDME. But when we labeled it with the data from OCT, it could correctly identify it as a center involving diabetic macular edema. So definitely by this way, we are improving the efficiency by using a labeled DME data from OCT. Can it be used to predict progression of DR? This was one of the work which was done by Google on the Thailand data. And they tried looking at 3-field color fundus photographs. And they also added the traditional risk factors, and they could predict 2-year chance of progression directly by using deep learning with the AUC of 0.84. Still, a lot of development have to happen. They also predicted that even using a single field, along with the traditional risk factors, they could get a good AUC in predicting what would be the risk of progression of diabetic retinopathy. Can we predict other microangiopathies? And this was one of the work which we did with Cambridge consultants, where this was using the SN Dreams, our population-based study data set, which had diabetic neuropathy data. So if we labeled the images, the retinal photographs with the neuropathy data, and it could detect diabetic neuropathy with accuracy of 0.8, and on the test set about 0.7. And to our surprise, in the presence of diabetic retinopathy, the accuracy improved. So in those cases who had retinopathy and neuropathy both, it could detect neuropathy much accurately. Can it predict the response of therapy? There is a lot of work which is happening in this field, and I'll share some of the work which we are doing at Shankar Nethralaya. This is one of the study which we are doing with Zeiss, where we are looking at change in the OCT after anti-VEGF injection, and the percentage reduction along with the clinical data, the prior number of injection, the HbA1c, duration of diabetes. We have developed a deep neural network, which is reasonably good accuracy in predicting the percentage reduction. So people have tried using only OCT data, and it has not been that encouraging. But what we realized that when we add the clinical data along with it, definitely the predictions are much better as compared to only using the OCT data. There's another work that's a very interesting work. We wanted to identify, can we identify the inflammatory component of DME just as a surrogate measure to assess a non-response? And for this, we looked into, you can see these 17 characteristics, the hyperreflective foci, the severity, the distribution, hard exudate. So these were all inflammatory markers which people have suggested. And we used uveitic macular edema, and we annotated each of these findings and trained an algorithm which could detect these lesions. So this was on a data set which didn't have any angiogenic component. It was only inflammatory component. And then we used this algorithm on patients of DME. And then also tried looking at, can we identify the responder versus non-responder? So you can see, though the responder non-responder is not great, that means there is much beyond the inflammatory markers which assess the response. It's not only but you can see for the DME and uveitic data set, the performance on individual B scans and even the volume scan was pretty good. So this is a different approach we thought of looking at. Can we identify how much percentage of a macular edema is inflammatory? And lastly, trying to predict systemic abnormalities. Again, this is one of the work done by Google Health, where they tried predicting from the retinal images the risk of the cardiovascular event, the MACE score, with an accuracy of 0.7. It could predict with reasonable good accuracy the age, the gender, smoking, non-smoker, men or women, or on all these things it could predict pretty well. And all these added to a score which could predict the risk of cardiovascular event in future. A more disruptive technology, which is just in preprint, is something which is mind-boggling. Can we detect diabetes from external eye images? This is again a work from Google Health, a huge data set of nearly 2 lakh external photographs, and they could very accurately detect presence of pre-diabetes and diabetes from external images. And you can see the heat maps showing the paralimbal area as something, probably the vessels there it is looking at to identify whether a person has diabetes or not. This is something which we'll see in future. Probably we may not need to do any blood sugars, just taking external image, it could predict with a great accuracy presence of diabetes. So what does it mean to train a model? Just a very basic, some facts about AI. So there is rule of 3. So you should know what is your objective. Mainly it is like detecting diseases from medical images. You need lots of data, labeled data, fairly representative of this disease. And then you want to have a model, a continuous optimization of this model so that you get good accuracies. So it is something like, whether it's a cat or dog, you have labeled photos, the data, and then the model, which is a deep neural network, finally suggesting whether it is a cat or a dog. And you replace this with a glaucoma image, whether it is glaucoma or no glaucoma, again, a deep neural network looking at, so you have the objective, you have the data, a well-labeled data, and then finally a model is developed. So coming back to the question that how will AI help us manage diabetic retinopathy better? In multiple ways. It can be used for screening, can be used for diagnosis of the disease. Many of the OCT algorithms today are based on AI, and definitely has got a potential to alter or identify the responders, non-responders, what would be the best treatment for them. And all these things, predictions will play an important role, which we cannot do with that accuracy. And when will we see all these coming into clinical care? I always say it's something like we have seen money really transforming in last few years. Now, we could never have imagined a couple of years back that we'll do the payments from our phone, but that has become a reality, and same is true with many of these AI technologies. I'd like to thank my team, research team, and my retina department colleagues helping me do this research. Thank you.
Thank you so much, Dr. Rajiv. Any questions from the audience, they can post in the chat box. And I'd like to ask any other questions from the panelists also.
Can I ask a question?
Sure.
Okay, Dr. Rajiv. So I work at Eye Hospital, which has a large charitable as well as a non-charitable wing. And apart from outreach areas where we get our patients, we also have local patients coming in from where we service. So I'm planning to start a facility where the small physicians looking at diabetics are able to screen their patients at their clinics itself. Yes. And as a pilot, I'd started a project where I gave one of them a handheld camera, and they took the pictures of the patients waiting in the clinic, and then they WhatsApp those images to me or email them. So met with some partial success regarding the quality, etc. Would you have any suggestions for me?
It's a very good thing what you are thinking, because that's the ideal way to screen a diabetic at the diabetic clinic. The only thing is, it's a difficult thing for them to take images. I don't know how you could convince them, because for them, that becomes the least important. That is one. Second thing is, have a registry. You don't want the same patient should be taken again and again.
Okay.
So at least make it
Maybe
sure
a
that
phone number or an
phone
Aadhaar
number
card
or something should be there, so that you are no. And non-mydriatic is good, definitely, but if you are getting a non-gradable image, which even your photographer or the person who is taking knows, he can retake the image. Again, dilatation is something which is a bit question whether to do it or not. And There are legal issues to it. But in a presence, if you can still dilate, but telling all these details to the patient, if he can do a simple Von Erich grading and probably dilate, if it is a non-gradable image, because you want maximum patients to get a gradable image.
Right.
And once you dilate the pupil, the non-gradability reduces from nearly 30% to 5%. So definitely it is a good tool to make an image gradable. So you can utilize it selectively. I think important is, I don't know what is the motivation level of physician, because that's you need to make it sure that they continue dilating the image and taking the images. I think
they can say that the patients will be saved the time of going to an ophthalmologist.
That's ideal thing.
At least a sort of, and they just give me the center view. Now, how good would that be in predicting?
American Academy has very well said that a single field 45-degree camera is pretty good for screening. Yes, we know it can miss many things, and you need to give those disclaimers very clearly that this is based on single photo. And definitely it is not a replacement for a complete eye exam. You need to put that. But definitely it's not a bad idea to use a 45-degree single field.
Right. I think I'll work on that. Thank you so much.
Any other questions? Yeah.
In case of litigation, who will take the responsibility?
Ophthalmologist.
Ophthalmologist or the hospital?
We can ask them to sign a consent, sir.
Consent, yeah. That's what you need to put a consent. See, you saw when we use it, first step is taking a consent.
Yeah.
So
Rajiv, this is just a screening. Can be erroneous, etc.
Yeah.
So I have a few questions, Rajiv. This is for a lot of people who are viewing this program, who are general ophthalmologists. They may like to understand the process of how this AI was established. You said gradable images. So who grades them in the first place?
Yeah. So what happens is whenever you are trying to develop something, the deep learning algorithm, AI algorithm, you need a data. So you have images. Now the ground truth has to be very robust. Now, in case of diabetic retinopathy, it is grading of retinopathy. So there are multiple ways to do that. You can have, like for the Google paper, we had 50 ophthalmologists in US who graded it, board certified, and we took the majority grade as the final grade. We also tried for the Thailand one, we used a retina specialist education. So we had 2 people grading, and if there was a discrepancy between them, then you add third person. So there are a variety of ways you can do the grading, but how accurately it was done or how reliably you can say this grading is, because based on that only the AI algorithm is made. So that has to be good.
So you said 50,000 images, above 60,000, it doesn't make a difference.
Yes.
That means for every aspect of a grade, say if it is particular grade, or if you consider the DRSS pattern of there's so many patterns are there, 1 step, 2 step, 3 step, whatever those patterns, all these have been graded. That means for each step or each grade, you have to have about 60,000 images, which is a lot of work.
Yeah, so this 60,000 was for referable DR. So our first study just wanted to look at moderate plus diabetic retinopathy, moderate NPDR plus, anything beyond that, how accurate it is. And for this study, we had used about 138,000 images. And it was all graded by multiple people. And then we realized that after this is called as tuning of algorithm. So you have training and tuning. So tuning, we started realizing that after 60,000, if you increase the number of images, the performance is not changing much. Now, this may not hold true for an AMD or even now people are using for rare diseases where you may not get so many images. So there are methods like what I showed the last one, the uveitic one. There we had done a data augmentation. So there was a lot of class imbalance. There were some conditions which were very less, some were very high. So we augmented the data, we generated the images. So there are a lot of these tools which people use now. But if like if you want to only use the data for DR1, we found 60,000.
So with your data and the software available, is it possible now to have a digital camera placed in a diabetic specialist clinic where he takes the image, looks at the
Exactly.
software, and
Yes, it is very much true.
the specialist knows whether this is a referable case or not referable?
Yes, yes.
It is
With a good accuracy.
today?
Yes, it is possible today.
And
We are doing it.
how much will it cost for a diabetic specialist to have that camera with the software to be able to?
That is a problem. It is not like commercially. I think Zeiss has got the one which we will soon come out with the result of Zeiss camera. So Zeiss has got a camera with a AI algorithm which they have, but commercially available Forus has got, I think, some algorithm, and a couple of these cameras have these algorithms. Only thing is, many times they don't disclose which is the algorithm, because it's these algorithms only which are all published. Somebody has sold to them, which they are using it. Yeah.
Yeah. So if we do it by Forus and we grade an image and we go wrong in it, Forus is not going to be responsible for it.
Yeah. Forus will not be responsible. That's the reason I'm telling you that you need to be pretty sure your intent of use, and as I told you, how the algorithm, you have to ask more details about it. That, like with Zeiss, we got all the ground truth that how good are they. Once we validated it first at our hospital, and once we saw that results are pretty good, then you roll it out.
Rajeev sir, just one question. Like you have been, I know this in SN, this medicine program is going on for a long time, and you have been doing this artificial intelligence work. It's very good. In my area, I have come across many physicians actually, and like you were talking about Zeiss and Forus. So this is my personal experience. One of the doctor who was a diabetologist, somehow they got the Forus fundus camera like put over there. So I realized that importance of the technician who is taking the images, to know that immediateness is very important in these cases, because the quality of images was not very good from that place. So I was very hesitant. Every time I used to write like in a legal terms that you need to clinically correlate and do this thing.
Correct.
Second time when I got this from the Zeiss side, and they have also installed their fundus camera, the quality was very good. And I was really impressed with the AI thing that they have labeled the microorganisms, other things. And wherever they felt that there was some discrepancy in the quality of images, they referred the patient to this retina specialist. So I think this makes a difference. Which device you are using and what algorithm you're using, it makes a lot of difference.
Yeah. So device, as I told you, device, definitely we know that some devices have got a higher resolution camera, some are better. Always stable models are much better than a handheld model. So we have many information about it. But as far as AI, the moment you're planning to use, you need to dig more deep into it, the questions which I had asked, because these are the ones you want to really know before you use it live on your patient. Yeah.
One more thing, that in artificial intelligence, all the algorithms, they are majority of them, they are done in the Western setup, European and Americans. And you might be using the same algorithm for Negroes and for Asian population, which will be having different response in diabetes to retinopathy or development of retinopathy in diabetes, because it is a different scene from race to race. So is it true that we can
No, I agree with you what you are telling, but whatever papers I showed, all are using Indian eyes images. So whatever I was showing, so even the first paper, majority images were from Shankara and from Arvind. So all these papers which I showed, even the Hong Kong paper, all are our images. And this was a comment which came as an editorial by Dr. Tin Wong, who suggested that these algorithms may work much better in Indian eyes, whether it will work for a Singaporean eye or a US eye. And then they did a multi-ethnic population, they validated it. So it seems that once a person has retinopathy, though the color of the fundus may be different, but lesions are same. And when it looks into the deep learning looks into these patterns or diagnoses a disease, it doesn't look into the inherent pigmentation of the fundus. It's the lesions. So for fundus photo, many of the algorithms, that's the reason even I know a company in US, they made it only on US population and we used it. And similarly, the Korean one, it was developed on a Korean insurance data set and from Korean hospitals, Medivales, and we used it. In our population also, it is performing pretty good. So it depends on what is the purpose of the thing. But I agree with you. This was a concern which even editorial had given. But after that, there have been a lot of studies. And now another trend is people are looking at multi-ethnic population. Like this wide field imaging, it was by Dr. Carol Ching in Hong Kong. She made the algorithm with her team. And she wanted it a multi-ethnic population. So we joined her so that there is a representation of Indian population, even from European population, US. So nowadays people are taking into account the multi-ethnicity factor too.
Sir, I had a question. Good evening, sir. Sir, I wanted to know whether in all this research, have we been able to find out more about newer OCT biomarkers using AI? I mean, we know we are still training the machine what we know. Is it the other way also, that the machine can tell us more than what we know?
I agree with you, but not much work has been done. The problem is again labeling and the question. So for our inflammatory disease, one marker which I had done study, we looked into the known markers, the OCT markers which are there. But we did a little interesting analysis at the end, because we also now we had the AI algorithm which could suggest that how much is inflammation in terms of number. It could give a score, that what is the inflammatory score in this OCT image. We used responder, non-responder. And then we tried looking at giving weight to individual of these markers. And there were some good surprises, like hyperreflective foci. What we found that it is not the severity of hyperreflective foci which is important. It is the distribution which is more important, whether it is in the central or whether it is in the inner or the outer retina. So there are some findings, but what you said is a very right thing, that probably we can identify new biomarkers using AI. Good evening, sir.
So Dinesh, you're muted. We need to first welcome, Dinesh. We want to welcome Dinesh. So Anupma should do that before Dinesh speaks, and we need to go on, because if there are so many questions to be asked from Rajiv, but we have to have the meeting completed from other aspects as well.
Yes.
So I welcome Dr. Dinesh Talwar also. And we move on to our next talk by Dr. Ajay Arora, who is the secretary of our very own Noida Ophthalmological Society. He's been 34 years into the practice of vitreoretina in Delhi and NCR. And he will be talking about ILIA. How does ILIA fit into his diabetic practice?
Anupma, you make me feel and look old. But anyway, so Dinesh, so before I go on, Dinesh is a very good friend. He is one of the most prominent ophthalmologists of the country. And it's always nice to have Dinesh on any webinars if you want to discuss out any event. So all the case presenters, you beware that you are going to be pulled left, right, and center. Dinesh is here and you're going to be asked questions. We want to make this session very lively. We are Dinesh was a senior consultant at AIMS before he left and joined Center for Sight. He is a senior consultant at Center for Sight and at RNG Netralaya in Horscars, and is a senior consultant with Retina at Apollo Hospital. He actually needs no introduction. He has numerous publications and presentations in national and international meetings. Welcome, Dinesh. It's a pleasure to have you, and thank you for being here. I'll share my screen. And
why are you using me as your shoulder to fire your gun towards your own?
No, I'm not doing anything.
मैं क्यों question पूछूंगा, तू पूछेगा.
चलो ठीक है. Okay.
Go ahead.
So is my screen visible?
Not yet.
No.
Oh, okay. Is it visible now?
Yeah.
Yeah, visible.
Yes.
Okay, thank you. So this is going to be a little boring because I thought I'll present a lot of cases. However, there is a lot of data which our sponsors also would like me to share because where does aflibercept fit into my diabetic practice, and I'll try to do justice to it. That's a disclaimer, and I, as NOS, would like to acknowledge the support given by Bayer India for today's event. Thank you, Bayer. So these are my financial disclosures. We know that anti-VEGF therapy has become the standard of care in DME, and that is what the protocol I had told us. We know that anti-VEGFs are effective irrespective of the initial visual acuity, irrespective of the type of OCT, whether it's a spongy edema or cystoid edema or any other presentation other than tractional edema, or whether it's a focal or diffuse diabetic macular edema, or when it's edema, DME associated with various grades of diabetic retinopathy. The number of injections, we know whether it's aflibercept, bevacizumab, or ranibizumab decrease over a period of time. This may be related to the disease-modifying ability of the anti-VEGFs. There is an efficacy difference between the anti-VEGF therapies for patients with the lower vision, and that is what I'll be showing you in greater detail in protocol T. And there's a large cost difference between various anti-VEGFs, and that is the tragedy in our country. And we are thankful to Bayer for introducing the idea for you program. The anti-VEGF therapy is non-inferior to PRP and PDR, which has been shown in the protocol S study. So aflibercept had been approved for use for DME way back in 2014 by the FDA, and Regeneron announced it on 29th of July. DCGI in India has approved use of aflibercept for DME as late as 22nd September 2020. And now with the IDEA for You program has been extended all over India, there's likely to be a greater use of aflibercept in diabetic patients also. A little bit of data which this paper beautifully summarizes. I would encourage you to go through it. And this is in the current opinion, which says that at 1 year, all three antivascular hereditary growth factors, so this all aflibercept, bevacizumab, and ranibizumab was used. And at 1 year of age, they showed that patients who had a visual acuity of better than 20/32, there was not much difference, but all patients with a visual acuity of 20/40 or worse, that is between 20/50 to 20/320, patients did better with aflibercept. This thing narrowed down in the 2 years' time. The aflibercept did remain superior, but the difference between aflibercept and ranibizumab reduced, but there was a difference with the bevacizumab. So the key messages for my entire program, if you understand this particular message, that is enough for this entire session of mine. Aflibercept is particularly useful in DME in cases with a visual acuity of less than 6/12 or 6/18. Aflibercept specifically traps VEGF and placental growth factor, which are present in high concentration DME cases. Other agents only act on VEGF, so aflibercept acts on both the factors. Aflibercept inhibition of VEGF and PGF leads to a disease modification in DME, and this seems to be to a greater extent as compared to the other agents. If we treat the patients intensively during the first year, there is possibly modification of the underlying disease, which leads to a reduction of the number of injections subsequently and a better long-term visual outcomes. The real-world data supports protocol T. We also have to know the fact that aflibercept has a highest binding affinity as compared to ranibizumab or bevacizumab. It's almost 100 times more than ranibizumab for VEGF-A. And this is again showing you the results of comparison, which was published in ophthalmology between aflibercept, bevacizumab, ranibizumab, which showed a superiority of aflibercept at 1 year, narrowing down the superiority between aflibercept and ranibizumab at 2 years, and the difference persisting between aflibercept and bevacizumab. Interestingly, there are higher events, adverse events were noted in this particular study with ranibizumab at 2 years. We would have anticipated greater events for aflibercept because of its higher VEGF suppression, but that actually is not true. So similarly, in the 5-year outcome, it's been shown, which I will allude to a little later. And this, the basic purpose was that after the 2 years, these patients were left for 3 years. Most of them had at least one visit to the clinic. Most of them, about 60% of them had one injection. Not all of them were injected. And they compared these patients at 5 years with the 2-year data. So among the 2/3 of the eligible protocol T participants who completed the 5-year visit, the mean visual acuity improved from baseline to 5 years without protocol-defined treatment after the follow-up. So this basically showed that the central subfield thickness, which was maintained at 5 years, and the visual acuity gain was maintained in 2/3 of these cases, persisted despite them not being actively treated in the subsequent period between 2 to 5 years. So a brief note about what protocol T is. This essentially is a comparison of 2 milligrams of intravitreal aflibercept given every 4 weeks versus 1.25 milligram of bevacizumab and 0.3 milligram of ranibizumab, because this study was done in the US, while internationally we use 0.5 milligram. And then the primary outcomes were analyzed at week 52 and subsequently at 2 years, and the extension study at 5 years. So what did we learn from protocol T? So what we found that protocol T, there's a greater visual gain, as you can see here, about 13.3 letters at the end of 1 year as compared to 11.2 with ranibizumab and 9.7 with bevacizumab. So there is a difference of almost 1 line between aflibercept and bevacizumab. And when this is extended beyond 1 year to 2 years, the difference narrows down between ranibizumab and aflibercept, but it does persist, though a little narrowed down with the bevacizumab. The drying effect was superior with aflibercept as compared to the other two agents, and this persisted for 2 years when the patients were studied. When we did a subgroup analysis of patients who had poorer vision means less than 20/40 or less than 6/12. So these patients, how was the response? Here, the difference between the visual acuity improvement with aflibercept was much superior, almost a line difference with ranibizumab and almost a line and a half difference with bevacizumab. So this difference, to an extent, persisted between aflibercept and bevacizumab, though it did narrow down with ranibizumab. When we compared the visual gains achieved with aflibercept with the comparator, and this basically shows that when the visual acuity was better than 20/32 or when the visual acuity was good, it does not matter which anti-VEGF you use, but when the visual acuity is poor, it is better to use aflibercept as compared to other agents. So that was basically the take from this. And then if aflibercept is superior to ranibizumab 1 year, but not at 2 years, why still consider aflibercept instead of ranibizumab in the DME group? So then they looked at the area under curve, and they looked at and they showed that the area under curve for Eylea or aflibercept was much more than ranibizumab and bevacizumab. And this clearly shows that for patients with a visual acuity of less than 20/40, aflibercept is better than the other two anti-VEGF agents. But if the visual acuity is better than 20/32, it doesn't really matter, even with area under curve, which agent to use. So we also know that there is a subfield thickness reduction. So was aflibercept better in reducing the subfield thickness for patients with a poorer vision? Yes, the central subfield thickness reduced much more with aflibercept in these patients who had poor vision. That means patients who have a thicker retina and have a poorer vision are likely to respond to aflibercept better than the other two agents, and that is what this graph showed, that if the retina has the visual acuity is better, and even if the retina is thicker, the response of ranibizumab and aflibercept is almost similar, but bevacizumab is not as good. This is again showing the same difference, that patients who had a worse central subfield thickness actually improved more with aflibercept as compared to when other agents were used. Now, when we compare patients requiring laser for treatment, it was seen that the aflibercept group required lesser amount of laser as compared to bevacizumab and ranibizumab over a period of time. For paucity of time, I'll run over some of these things. And so when we look at the change of the DRSS scales, we know that the diabetic retinopathy severity scale has classified diabetes into 13 levels. And if we look at the scale at baseline and at 52, this is the data provided from the study group patients. So if you look at this data, which was a baseline, and this is at 1 year, you can see that there is a two-step improvement in the DRSS severity scale with the reduction of hemorrhages, with the improvement of macular edema. So this is the improvement in the diabetic severity scale. On post-hoc analysis, when we look at the prevalence of diabetic macular edema, if we look at this period, we see that at week 24, the blue one is the persistence of diabetic macular edema was less with aflibercept as compared to bevacizumab. The ranibizumab also came nearer. But when we looked at, with the extension of time, we found that aflibercept actually the edema was much less as compared to ranibizumab. And if we look at over the period of time, the probability of the chronic persistent diabetic macular edema at 2 years, we found that the chances were about 44.2% with aflibercept, and they were much higher with ranibizumab or bevacizumab in the group where the edema was persisting after. Now, the real-world evidence supports protocol T. We will just rapidly go through it. This is the Apollon study, which confirms what was shown by the Vivid DME study, which again shows that patients who had poorer visual acuity respond better to aflibercept as compared to patients with better visual acuity. We'll just rapidly running short of time. So Euretina guidelines have shown the recommendations are, they recommend that anti-VEGF therapy is recommended as the first-line therapy. Euretina also recommends aflibercept as preferential treatment for patients with a visual acuity of less than 20/50. And they say that aflibercept equivalent to other anti-VEGF agents in eyes with visual acuity better than 20/32, you could choose any particular agent. This is a similar recommendation has been made by other Asian countries, and in a Cochrane analysis, it's been shown that aflibercept, bevacizumab, ranibizumab were all more effective than laser in improving visual acuity, and all of us know that. Patients are 30% more likely to gain more than 3 lines with aflibercept than ranibizumab or bevacizumab at 1 year, and this is particularly for patients with less than 20/40 vision. All patients at 1 year outcome favored aflibercept over ranibizumab and bevacizumab. Ranibizumab and bevacizumab did not differ in terms of functional outcomes. So this is what the Cochrane data has shown. And as far as what we try to accommodate or we try to follow in our clinic, we feel that aflibercept should be the treatment of choice as an anti-VEGF for patients who have visual acuity of less than 6/18. We have very limited data at present because aflibercept has been approved for DME quite recently, and the Eylea for You program now that is available for DME as well. I think we'll be using it more often. We try to give aflibercept monthly for 3 months and then extend it every 2 months. But there are patients where we go out of this, that if the patient has responded well at 2 months, we start extending them beyond 2 months as well, following a PRN regime with a treat and extend, a combination of treat and extend and PRN in this situation. We tell all our patients that they will need more number of injections during the first year and lesser thereafter. So they are and the economy should be worked out with the patient before itself, because if the patient is not able to afford the entire treatment, there is no point in starting it and then giving it up and going back to the other agent. So sometimes we have done that, started with Avastin and subsequently switched over to aflibercept. The patient themselves wanted, because when they first time hear about the number of injections, they're afraid, and for easiest for them is to get Avastin. We give them an option of, in our clinic, we give them also an option of a micropulse laser once the subfield thickness is reduced. So this is not part of any of the protocols here. We are just doing it, and we found reasonable results. We have not yet reported it, but yes, we are offering this to our patients, and we are thankful to Bayer for the Eylea for You program for DME, and this certainly is helping our patients. Thank you for your kind attention.
Thank you, Dr. Ajay. It was a wonderful talk. Any expert comments, Dr. Talwar? Any expert comments from your side?
Well, I think basically, if you see that graph of aflibercept, and the other drugs in protocol T, you'll see that the maximum differentiation between aflibercept and the other drugs comes in the first 12 weeks. So there's actually a case for giving the first 3 injections of aflibercept and then trying to do maintenance with ranibizumab. Maybe a bigger center like Rajiv Raman's can do that and practically validate it. Because the thing is that if all of them work in the maintenance phase, then the difference is coming in the initial phase. And if that initial phase we can tide over with aflibercept, then people who are not so well off can also be given the advantage of aflibercept and then maintained on one of the other drugs.
I agree, sir. That's a good thought, that initially starting with Eylea would be to get the maximum benefit of both the worlds, using Eylea, and then probably this program, the Eylea program has actually helped, because initially when they started, it was eye-wise. So for AMD, it was useful, but the moment DME, I told it will be needed in both the eyes. So you calculate patient, so even I can switch over between the eyes.
Yes.
So that has actually worked pretty well, because you take the first and then there are a couple of these free injections. So at least 2-3 injections are taken care in this program for both eyes.
You can have 5 in the price of 2.
Yeah.
That can enable your first 3 injections in both the eyes.
Yes,
and
that's
then
what.
You can maintain them on a cheaper drug if you want.
Correct. I agree with you.
So Dinesh, if you need 3 injections in each eye, you basically need 6 injections, which means you switch over.
5 तो वही है ना इसमें.
5 तो 1 बच गया ना.
हाँ तो अरे जो if they respond within that, then कोई तो आंख respond करेगी. ये थोड़ी है कि बिल्कुल ही नहीं respond करेगा. जो respond कर गया, 3 is the average number of injections it requires to differentiate from the others.
Yeah, I agree with you. But I think this needs to be validated, that you're switching over from. So when you change over from aflibercept to say Avastin, the patient will ask you, "Kisa agar aap Avastin use kare, why did you use aflibercept in the beginning?" So you need to explain it.
Yes. So similar. There's another thing which you will notice if you see the slide set with aflibercept. The important thing that's now coming up and started with Rise and Ride was that you can turn the clock back on the diabetic retinopathy process.
Correct.
Correct.
right? Now, if you see, when it comes to proliferative diabetic retinopathy and DME associated, aflibercept is better than ranibizumab.
True.
Yeah, so one of the indication
But
is
when you come
definitely
to
severity.
when you come to NPDR with DME, ranibizumab is better.
No, but then again,
No,
the
no, no.
vision
They're
criteria.
If
see,
you see their own graph, you know, there is a difference between PDR and NPDR. NPDR is with DME. PDR is the most severe point where you are. So in that severe situation, if you're trying to reverse the situation, then aflibercept is a better drug. But when it's less severe disease process, NPDR, you may actually get away with ranibizumab. That's the important thing.
I agree. What you're telling, how I take it clinical practice, because you have only two stages. You have the moderate NPDR, severe NPDR.
Yes.
So I take it in my clinical practice above severe, I always advise for aflibercept. Because again, one of the messages that with more severe stage of retinopathy, if there is macular edema, Eylea seems to work better.
Yes.
So I do, because mild NPDR with macular edema, we don't get usually. So it is moderate. So if it is moderate, as you rightly said, you can use both.
Yes.
So that time my decision is mainly on the thickness and the vision. So if you have a thick retina, poor vision, fulfills the criteria, probably think of Eylea, otherwise use anything.
Yes, that's so that's another important. See, these are specific places where aflibercept scores over the other drugs.
Yes.
You know? So.
So essentially, we can say the take-home message: if you have a severe disease, if you have a greater thickened retina, and if you have poorer vision, you should try to use aflibercept. I think that's the bottom line.
So if you have a thickness of more than 400 micrometers, if you have severe NPDR or early PDR in association with DME, these are all indications for going in for aflibercept primarily, as compared to the other drugs.
Dr. Talwar, can I ask a question?
Yeah.
So in DME, we find that the first year we give 6 injections, and in the later years, the number of injections the requirement becomes lesser and lesser. Is the same thing, does it continue for the DRSS score also? Or does that worsen when the number of injections come down?
No, see, you have to be very careful about this DRSS score, because there are studies which have shown that the DRSS score comes down, but the ischemia doesn't come down. The CNP areas persist. So on fluorescein angiography, there is no change. The change in terms of capillary non-perfusion. The change is in terms of leakage. The change is in terms of the NP, the features you're seeing clinically on the clinical examination. But if you leave these guys alone, you remember that if there are extensive areas of capillary non-perfusion, everything will come back. And this is the biggest problem with protocol S also. It's a great thing you can manage, but the moment you leave it, that it hits you back. In fact, there was a study in which they picked up patients who had gone through monotherapy, and then for some reason or the other, they had to discontinue, or they could not come back for 6 to 12 months.
This is DME or?
No, we're talking of
PDR.
PDR. 50% of the eyes were lost. Okay. So
whereas the effect on DME has a legacy, it lasts a little longer.
Yes. So see, DME is a very forgiving disease compared to PDR. PDR is not a forgiving disease. So what you're talking about, DRSS, yes, the score will help. Maybe that would be a good time to do a fluorescein angiography, pick up targeted areas of CNP for laser, and finish off the disease process on a long-term basis. That would probably be the ideal way to manage these patients, so that you don't need to do the laser into the posterior pole. You're doing the laser right in the periphery. You don't get any effect on the visual fields, so you are okay.
Shana, the protocol T extension data, which was presented last year, 5-year data, which showed that between 2 and 5 years, there were many patients who did not receive an injection at all.
Correct.
And most patients, there was 2/3 of them received only one injection.
That is why I asked this question.
Yet the DRSS score did not deteriorate correspondingly. So that basically means that there is a disease modifying thing happening, which people at the moment don't understand what is happening. We may have CNP areas, but those CNP areas are there on angiography, but they may not be leaking VEGF.
No, they don't leak. No, this is
not leaking. They may not be producing VEGF.
The basic thing is,
so if the VEGF production has been modified to that extent that it is blocked and there is no VEGF production occurring from those CNP areas are structural areas on angiography.
No, possibly it is not that it completely blocks it, but it reduces it significantly, so that the effect is not coming back on the macular edema.
So whenever there is
in terms of proliferation, but the basic thing is that is a time bomb ready to explode sometime or the other. So that's the only thing. So that is why it's not to be ignored.
Not to be ignored. So whenever we say that disease severity is more, we use aflibercept, it is actually tantamount to increased VEGF production. If you have a severe disease, you are likely to have a greater VEGF in the vitreous tumor.
No, that's okay.
If you have a less severe disease, so
once you've gone through that, you've treated the patient. Now you've got a reversal by 2 steps. It's gone to mild NPDR, but it's gone to mild NPDR in terms of clinical features. But if you do a fluorescein angiography, leakage may not be there, but the capillary non-perfusion areas don't go away.
Agree. They don't go away because there's a structural damage of these capillaries long time back.
Exactly. Yeah. So what has happened is the capillaries which are dead are dead. Those which are blocked can't reopen. See, basically the capillary dropout occurs because of these capillaries. Once the pericytes and the endothelial cells go away, the capillaries get blocked away. Once they are blocked away, they can't come back. Now in that area, as long as that area is hypoxic, it will produce something. When it is anoxic, it will not, but it will look the same.
So it is looking same and not producing VEGF.
True.
It's okay for us, yeah.
That is something. No, that is not proved. So please don't give that message because
I'm not giving that message. I'm just saying.
So I think we need to
understand it better. We don't understand it
at
now.
This moment, I would use that period to destroy those areas of capillary non-perfusion which are in the periphery. It's a simple thing.
With a laser.
Rather than saying कि मैं watch करूँगा कि ये वापस आता है कि नहीं, क्यों आएगा? Why should I watch?
Agree. Yeah. Unless and until Rajiv validates it by some study, till that time.
What Dr. Talwar is telling is correct. The CNP areas don't go away. But saying that probably why the DRSS score is not much changing in these clarity and the other study name, what was it? Clarity is with this. There are 2 studies with it. So why they have not changed much is probably the majority of patients must be in the moderate NPDR range. We really cannot say unless and until we prove it correct.
Right. So I think we'll go on to the case discussion. But before that, there is for the sponsors, I have to run a small video. So allow me for that. I'm sorry, Shahana, but it needs to be done. I'll just try to share it because it's a small video.
You just had an entire presentation on all that.
So we can do it in the end if you want.
Yes, please.
Yeah. So let's go on with the case discussion. We do that video in the end. So please go ahead. So we'll request Dr. Shahana, can you start the process?
I thought you were going to do it.
Okay. Wait a minute. Just sharing. Okay. Yeah, so we have with us, just one second.
I think Dr. Ruchit Tiwari will now.
Ruchit, let me just check the order. So I think we have with us Dr. Ruchir. Dr. Ruchir Tiwari is a consultant at Tiwari Eye Center. He's a pass out of AIMS, and Ruchir is a young, dynamic, bubbling ophthalmologist with a lot of ideas. We welcome you, Ruchir. I think we'll start off the case discussion part. So we'll have Ruchir, then followed by, and with each presenter, we'll give a brief introduction. So Ruchir will be starting on the role of FFA and OCT in diabetic retinopathy. All yours.
Right, thank you, sir.
And just by the way, this is 6 minutes presentation and 4 minutes discussion.
Oh, right, sir.
Yeah.
So is my presentation visible?
Yes. Yes.
So good evening, everyone. First of all, I would like to thank Noas and Ajay sir for giving me this opportunity. So I would be talking about the role of angiography and OCT in diabetic retinopathy. So there are no financial disclosures. So I'll start with my first case. The patient is a 67-year-old male who presented with complaint of blurring of vision in both his eyes. Now he does some fine work. So his main complaint was there was feeling of unease when he was doing his work. He is a diabetic for 25 years and his recent A1C was 8.5. On examination, his BCVA was 6.9 in both eyes. He had a history of cataract surgery done 1 year back, and he had received 2 injections ranibizumab in each eye for DME and VMT. So when I looked at the fundus, this is the fundus picture of the right eye. The optic disc is looking okay. There is a grayish membrane over the macular region. There seems to be some vitreous hemorrhage near the inferotemporal arcade. The left eye again shows a normal looking optic disc, and there are a few hemorrhages. Otherwise, the fundus is looking all right. But on a closer inspection, so I do an OCT and I see that the membrane that I was seeing in the right eye was actually a thick taut posterior hyaloid. The central foveal region looks okay, although in the parafoveal regions, there are cystic spaces present in the right eye. In the left eye, clearly shows a vitromacular traction with cystic spaces. So on a closer inspection of the right eye, I see that the area of interest is now the optic disc, which shows a fine meshwork of blood vessels. And I continue with an angiogram. So when we move ahead with the angiogram, the characteristic nature of the NVD is now visible. It's a meshwork of blood vessels, which starts leaking. And in the late phases, we can see profuse leakage from the optic disc area, and there are 2 small areas of neovascularization elsewhere. The other thing to note is the enlarged foveal avascular zone, which signifies some component of macular ischemia. Also, in the periphery, we can see large capillary non-perfusion areas. Later on, when I made a montage of the angiography, it is only the posterior pole that is perfused, and all the other areas are actually CNP areas. So this becomes a case of PDR with high-risk characteristics from moderate NPDR with DME, with which the patient was being treated earlier. Similarly, when we look at the left eye, there are 2 areas of interest. First is the optic disc, which again shows a fine meshwork of vessels. Also the superotemporal region, which shows a meshwork of vessels. So this is an NVE. So when we move ahead with the angiogram, the NVD is now visible, and in the superotemporal area, the NVE is also taking shape. So the NVE is now clearly visible here, and there are large CNP areas in the periphery. So when we look at in the late phase, again, there is leakage from the disc and there is leakage from the NVE. Also, there is macular edema. A typical petaloid pattern is now visible. So when I make a montage, again, only the posterior pole is perfused. There is an NVE, there is an NVD, and there are large CNP areas along with DME. So I went back to the OCT to get a complete picture of what was happening. And although the central foveal region looks okay, there are certain areas where the traction is still maintained. Similarly, in the left eye, the VMT has a component to the macular edema, and it is likely then that this patient may not respond to simple anti-VEGFs. So the diagnosis was now updated to both eye PDR with high-risk characteristics and DME, right eye with a thick taut posterior hyaloid and left eye with a vitromacular traction. The plan was to give 1 injection in the left eye, anti-VEGF in the left eye, and to do a complete scatter laser. The patient was also apprised about the need for future pars plana vitrectomy to improve his vision. if there was further deterioration because of the thick membrane in the right eye and the VMT component in the left eye. So with this, we move on to the second case, which is a 60-year-old lady. She was an uncontrolled diabetic. Her A1C was 13.5. She recently had COVID and was given a lot of steroids. So probably that led to the sudden jump in her sugar levels. She again complained of blurring of vision in both her eyes. VCVA was 6/24, and there was grade 1 nuclear sclerosis in both eyes. When we look at the OCT, the above picture is the right eye OCT. The central foveal region is looking more or less okay, with temporal areas showing retinal thickening and cystic spaces with a few hard exudates. The left eye picture shows a more or less normal looking OCT, although there are few cystic spaces in the temporal region. The fundus picture of the right eye again is showing a few superficial hemorrhages, soft exudate, few areas of hard exudate, but otherwise it is not looking a bad fundus picture to have. Same is the case with the left eye. Somehow I could not understand why the vision was low, and I thought that there could be a component of macular ischemia. So I went ahead with an angiogram. The right eye is now showing a distorted foveal avascular zone. Same is with the left eye. Well, this is a late phase, so it is difficult to comment, but it does show a little enlarged foveal avascular zone with a lot of macular edema happening in the perifoveal regions. As we move forward, the angiogram now shows 2 areas of NVEs in the right eye and 2 areas of NVEs in the left eye, and also large areas of CNP. So although the fundus was not looking that bad, when we do an angiogram, we do realize that there are large CNP areas, and this is not a case of moderate or severe NPDR. This is actually PDR. So again, the patient was advised both eye injection ranibizumab for the swelling and pan-retinal photocoagulation in both eyes. So I think the thing that I learned from these cases is that in long-standing diabetic cases of a very long duration, even a normal looking fundus can have abnormalities which are not picked up by naked eye. So an angiogram in those cases might be helpful in revealing the hidden features which we tend to miss. Thank you.
Excellent, Ruchir. Excellent. I think it's open for discussion. Would like to have comments from Dr. Rajiv, Dr. Dinesh, Dr. Shahana.
Nice cases. I think both the cases well documented. Many times you may not require an angiogram with a good clinical photo. If those photos, things were visible. Nowadays with wide field photography, you can really zoom in and see if clinically you have missed any NV. Especially anything more than moderate NPDR, have extra eye to try to look for these subtle NVs. And NVD definitely was very evident even on the color fundus photograph. So indications of angiogram definitely has reduced, but in selected cases where you are not finding anything, vision is not correlating, not bad idea to get a FFA, and rightly you picked up some good lesions.
One question to everybody: in case a patient walks into your clinic for the first time, who's a diabetic, and you decide to subject the patient to an OCT and a fundus photograph, and it's a patient of a moderate to severe NPDR, for the first time ever, would you also write a fluorescein angiogram?
Actually, Rajiv has the advantage of working with state-of-the-art equipment and with lots of fellows and all.
And an eye.
For a general ophthalmologist or for a normal person in practice, if you want to save time, the quickest way is with an angiogram.
Correct.
Within 5 minutes, you have your answers. You don't have to go for any magnification. You don't have to look at each little area. Technically, a fundus photograph is as good as a fluorescein angiography, technically, if you have enough time for it. But I don't think anyone ever compared how much is the time required to interpret a fluorescein angiogram and the time required to interpret the 7 fields in the same detail. So I would suggest that if you have anything more than moderate NPDR, one should do a fluorescein angiogram. in 5 minutes, you have your answer. So this is the importance. Otherwise, you may miss early PDR like you did. Like actually you did.
Correct.
If you look only at the clinical photographs, you would miss them. So you would have a doubt in the first case. You would probably miss it altogether in the second case. So that's the thing. In the first case, now. The second thing is, if you see a subhyaloid hemorrhage,
Definitely.
Your diagnosis is 100% you have a PDR. Now find out where that neovascularization is coming from.
Yeah.
So this is the other thing.
No,
So,
but Dinesh, if you have a subhyaloid hemorrhage, you know that it is PDR, would you still do an angiography?
yes, because I need to know whether it responded or not.
No,
What did I have
has come for the first
Yes,
time.
what did he
want to
have?
document,
What
yeah.
did I have before? And what do I have after my laser? I need to know whether it's working or not. I'll show you patients who for years, persistent neovascularization keeps on occurring and they keep on having small bleeds. Previously, we never used to bother. So,
Rajiv, at SN, if you have a patient with a subhyaloid hemorrhage, would you subject him to angiography?
Usually no.
And what is your
We
logic?
may do it for the other eye. If there is
Right.
a doubt and we miss everything and on clinical picture not there, for the other eye we may do. But when there is a subhyaloid hemorrhage, again, to pick up NV, I don't think we need to do. For monitoring of the therapy, yes, nowadays we have the SSOCTA, which we are doing more now. So nowadays SSOCTA has become a standard. Many times we use that. But yes, for monitoring, you need to have either SSOCTA or angiogram, as Dr. Dinesh told.
we need a wide field SS.
Wide field SSOCTA.
Which,
No, if you-
that's what I said.
SSOCTA is a wide field. The 12 by 12 montage.
जो राजीव के पास अब है वो हमारे पास होती
नहीं,
है
but
हमारी
राजीव के
photography
पास
कम
भी 12 by 12 है, and with the
with miss करते हैं उसमें भी.
OCTA on a Zeiss
वो भी miss
Opta,
होता है.
the Zeiss
But कम
Opta
होता
we
है.
have, it covers 14.6 millimeters. So if you document an NVE on that Opta, would you still do an FFA for the patient who's come for the
So
first
then I
time?
wouldn't, if I can see, let's be
But you
very
can't
clear.
pick up all the NVEs. Beyond
No,
that,
If
see,
you want
there
to
are
do
two
a
messages
targeted
going here.
PRP.
There are two messages going here. One is, what do I expect a general retinal specialist? I'm talking of somebody who doesn't have access to wide field SS OCT, who doesn't have wide field fundus photography. The normal fundus photo camera he has, normal angiogram he can do, normal OCT he has. He needs to make sure he doesn't make any mistake. And if you don't want to make that mistake, you need a fluorescein angiography. But if you don't have, if you have all these things, then you don't need it. If I can do a peripheral OCT and check up for neovascularization till the periphery, even my monitoring can be done with that. I don't need to monitor with a fluorescein angiogram.
yeah, so within your constraints, depending on what your constraints are, you decide for yourself, and the patient comes for the first time. It may be prudent still to go ahead and do an angiography and OCT as a baseline. And I think Ruchi showed beautifully those pictures, marked out those CNP areas, marked out those traction, marked out those. And I thought in first case of yours, there was a little bit of a vitreopapillary traction also.
Yes.
So that's what I thought. So those are the poor prognostic indicators. But anyway, we'll go on to the next case, which is by Anubhav. Anubhav is a consultant at Eye Care Hospital. He did his fellowship at Giridhar Eye Institute, and he is a very energetic person, always wanting to, do newer things. He's very active, and I think he has a lot of cases to show. But Anubhav, your time starts now. It's 10 minutes.
Thank you, sir. Thanks a lot for the time, and thank you for this opportunity. I'll be sharing my slides. So I hope my slides are visible. So I'll be starting directly with my cases. My first case is a case of a central involving CSME. Case has a history of diabetes, uncontrolled diabetes with HbA1c of 13.3 at my initial visit in November 2020, with high sugars at the time of presentation and defective vision in both the eyes. The right eye clinically was showing, both eyes were showing moderate NPDR changes with hard exudate deposition around the fovea, and vision in right eye was 618 parts and 18, left eye was 612 and 10. Angiogram also confirmed NPDR only, but the OCT shows significant edema, which is mainly in the form of SRF in both the eyes. It was 402 micron in right eye and 271 in left eye. I've advised anti-VEGF at that time, but unfortunately, because of COVID, patient didn't turn up and turned up after 8 months. And to my surprise, edema completely gone, visual acuity improved, and because of the counseling, his HbA1c has controlled to 6.1, and this has given a very good result. So this is an example of good metabolic control, which can itself give very good improvement without any intervention if patient is very aware and concerned about the treatment. Second is also example of a metabolic control along with anti-VEGF. This is a case in which I am presenting center involving CSME with diffuse leaking aneurysms on FFA. Patient has a recent drop in vision with HbA1c of 11.1 in October 2020. Both eyes have significantly decreased vision. Clinically and on FFA, both show significant NPDR, severe NPDR changes. If you see the OCT, there was a huge CSME in right eye of 650 microns approximately in September 2020 and 850 microns in left eye, which after giving 3 monthly doses of Eylea, it has come down to 416 in right eye and 403 in left eye. Patient was not willing to take injections after that. So vision also improved significantly. So I stopped injection at that time. After 5 months, patient come back with this is additional thing. The HbA1c controlled from 11.1 to 5.6 by the patient. So this is again additional factor which we saw that patient has done in this time. And with this controlled in HbA1c, patient has worsening after 5 months in macular edema in both eyes. Vision also reduced a bit in both eyes. But I have given 4th injection at that time, and to the magic surprise, the edema has completely gone with the 4th injection alone, and the vision has nearly improved from 6.6 and 6 in right eye, 6.6 parts and 6 in left eye. So if you see the progression over 10 months with massive, excellent metabolic control within 3 months and just 4 anti-VEGF injection, the vision of 612 parts and 8 in right eye and 618 parts and 12 in left eye has improved to 6.6 and 6 in right eye and 6.6 parts and 6 with completely resolution of edema with just 4 injections in past 10 months. So this is another example of good metabolic control along with anti-VEGF with minimal intervention in both eyes. So take home messages for central involving macular edema. Anti-VEGF therapy is the first line of treatment that everyone knows, but good metabolic control can help in early diabetic retinopathy stabilization with minimum intervention. Again, one more case of central involving CSME with juxtafoveal sarsenate. This patient came to me with vision of 6.9 and 6 with a nice sarsenate seen juxtafoveally and foveal involving SRF CSME. So initially, because of the central involvement is there, I give anti-VEGF followed by perifoveal laser to the centrally leaking microaneurysm in the sarsenate. And over a period of 3 months, if you see sarsenate has completely gone, vision improved to 6.6 and 6, and edema is completely gone. So this is another advantage of anti-VEGF in the study. So take home message in this is DME with extrafoveal sarsenate respond extremely well to combination therapy of anti-VEGF followed by focal laser and timely intervention. There is a 4th case which I am showing that in which vision was 6.6 and 6, macular edema was not there. But clinically, if you see, there was a significant hard exudate deposition, which if you just assess the clinical picture, you can diagnose it as a CSME and can plan for anti-VEGF. So if the vision is 6.6 and there is not much edema on OCT, such cases of clinically seen as CSME can be just observed with good metabolic control. So not all cases with clinically seen DME need urgent anti-VEGF treatment. Another case in which patient was having significant bad vision in both eyes. Left eye was having finger counting 3 meters, right eye was 6.12 and 8. And patient came to us with drop in vision both eyes, mainly in left eye. So this clinically, if you see, right eye was having a severe NPDR picture with minimal film shape hemorrhage along the inferior arcade, but left eye was having subhyaloid hemorrhage inferior to the lower vessel, which is showing clinically as a PDR. But right eye was seen as a severe NPDR query clinically. OCT shows significant CSME in the right eye. Left eye was having CME with vitreomacular traction. So this is FFA showing NVEs all around the periphery with the blocked fluorescence of hemorrhages mainly in left eye. So diagnosing as PDR in both the eyes. Since the OCT of right eye was showing significant CME also, so seeing the surface NVEs and edema, we planned anti-VEGF for this patient mainly in right eye. Left eye we planned only for PRP. So over a period of three injections, edema is completely gone, and to the surprise, NVE has also completely resolved, along with CNP areas. You see these all areas correspondingly showing significant improvement in capillary non-perfusion also. Octa in this area has shown nice NVE at the level of inner retinal surface. So this is a comparative image of right eye showing complete resolution after 3 anti-VEGF. And then as a standard protocol of PDR, we have given PRP. So this is a take-home message that as according to protocol as DRCR net, anti-VEGF, though is not inferior to PRP, result in significant regression of NVD and NVE. But it should be kept in mind that these are only for surface NVEs, early PDR cases, and should not be given in advanced PDR with fibrovascular proliferation with traction, because with anti-VEGF they can immediately worsen, and all these cases actually need surgical intervention rather than just anti-VEGF treatment. This is my last case showing DME worsening after cataract surgery. In this is a case with having pre-existing diabetic macular edema. After cataract surgery, it has worsened, and following which we have given anti-VEGF injection and showing improvement. So it is a recommendation that in patient with only with pre-existing DME, not in dry macular, pre-existing DME, anti-VEGF should be combined with cataract surgery for better results post-operatively. Additional thing which should be kept in mind that a careful peripheral examination should be done prophylactically in all the patients undergoing anti-VEGF injections or surgical intervention in terms of cataract surgery to rule out any peripheral lesion like lattice or breaks, so that we can prevent future risk of RD. So to conclude, good systemic control can alone improve retinopathy and vision. Anti-VEGF is the mainstay of treatment in central morning DME. DRCR net has reported that 32 to 66% patients respond nicely with anti-VEGF with improvement in CME and visual acuity. But DME stabilization is more important than complete drying of macula. The patient might not have complete dry macula. Minimal edema can be tolerated with stable retinopathy in this patient. Baseline fundus photo, FFA and OCT is mandatory in most of the cases, not in all. And careful IDA should be done in all the cases before any intervention in such cases. Thank you.
Thank you, Anubhav. I hope there's a lot of matter to discuss, but I'll open for discussion. Any comments, Rajiv, Dinesh, Shahana?
See, the most important of these is the fact about the role of control of blood sugar. Yeah. The hyperglycemia control is a huge thing for managing diabetic macular edema, and even in fact helping in your treatment of proliferative diabetic retinopathy, though it won't cause a regression of the PDR. The important thing, in fact, long back, I remember we were on I was talking to one of friends of mine in Mumbai, Dr. Parikh. So Vatsal Parikh, so he says, Dinesh, everyone talks about anti-VEGF all the time. I'll show you the same results without anti-VEGF. And then he sent me the same kind of slide, which just been shown, where we're purely on metabolic control over a period of an year, the same results were found. The point is, number one, you have to stress upon the need for metabolic control. And I do that for all my patients whom I start on anti-VEGF agent, both in terms of hyperglycemia and dyslipidemia and hypertension and nephropathy. 4 things which I always insist that they get checked for. Because at the time when he's very motivated. When a guy is spending $60,000 for an injection, he's damn motivated to get his blood sugar controlled also. It makes a lot of difference to hit him at that time. And that difference which we see at 3 years, nobody's actually checked out whether a significant component of that improvement occurred because the patient who's on monthly treatment with anti-VEGFs also realizes the importance of his diabetes control, and by the end of 3 years has actually controlled his diabetes. Anecdotally, let me tell you, recently in this COVID times, I have patients who for 6 months, they were confined, they took complete care. Guys जो हर महीने जिनको इंजेक्शन लग रहा था, वो मेरे को बताते हैं कि सर अब तो मैं बहुत बेटर फील कर रहा हूँ, and he keeps sending me his 2 weekly blood sugar, अब 82 fasting है, अब 87 fasting है. The guy comes to me and he's actually N6 and 6/9, and he's not received any injection for 6 months, not even Ozurdex.
So it shows how much we are over-treating.
It shows how much our patients are hitting themselves below their belt.
Yeah.
One question I have for all of you is that there was a beautiful paper from PGI with the lipid control and lipid all that. Do you people use phenofibrate in patients which Anubhav showed a lot of lipid in the macular area? So did Anubhav use any agents to reduce those lipids, or they went off with purely a good otherwise metabolic control?
Sir, I usually give atorvastatin 10 mg, or if there is extensive heart exudation, 20 mg daily. I usually add them. If
You can add phenofibrate like Stanlip or something.
Yeah.
As well.
I start all my patients, I don't start them myself. I send all my patients to a diabetologist, written very specifically to be started on anti-lipid agents. I write down in the brackets, preferably statins, for control of dyslipidemia, for management of diabetic eye disease. Otherwise, he'll say, "Mujhe zarurat nahi hai."
That's the thing.
So what
if the lipids are normal?
Under his supervision.
So even if the lipids are normal,
only if there's dyslipidemia. I get the lipid profile done.
Yeah.
Sir, even atorvastatin 10 milligram we have seen has not done major hardships to the patient in long run also. So even though lipid profile is normal for patient, if you have hard exudate deposition, probably we have seen that we can start at atorvastatin 10 milligram by ourselves also. And
see, my point is only I want to stay an ophthalmologist.
Yeah,
I don't want to take the headache of what has happened on a systemic basis with systemic drugs. Tomorrow you'll say, आपने diabetes के लिए कहा था ये दवाई ले लो, फिर तो मर गया मैंने, because फिर उसको hypoglycemia हो गया, hyperglycemia हो गया. In just today I had this patient, 360 का blood sugar चल रहा है, उसको स्टीरॉइड दिया हुआ है किसी ने AION के लिए, 2 महीने हो चुके हैं. मैं कहा देख मेरे को या तो मुझे माफ कर दे, या तो किसी फिजिशियन के पास चले जा.
Correct.
Yeah. So the thing is, what Ankur is saying is also that sometimes the patient may take a long time to reach a physician. Can you start them on this and tell them that please follow up with the physician that we are starting, but it's you have to consult a physician.
Once you take over, the physician never takes over. I'm not joking. I have this patient. I'm giving you an anecdote not related to this. I had a patient who, for vitreoretinal surgery, post surgery, had started him on steroids and stopped them on 5 days. 7th day he comes to me, I'm having weakness. So I said, talk to your physician. The physician told him, ये steroid जल्दी बंद कर दिया, इसको start कर दे, तो restart कर दे और धीरे धीरे taper करना. He did that. 3 days later, diagnosed as enteric. Okay. Now, when he's diagnosed as enteric, I say you talk to your physician. Let him decide what is to be done. The physician says, let the ophthalmologist tell you how to taper the drug. Because शुरू में मैंने बोला, he doesn't want to take responsibility. So once you write down something, it's your responsibility.
Now the problem is, if his lipids are okay, they will never start. And the ACORD eye study shows that the phenofibrates will work even if the lipids are okay.
So that's all right. So either you say I want it for the eye disease.
Yeah. So you have to have a
You have to
relationship with
tell.
the physician.
Yeah. That's what we have done. We have told our physician that this is the purpose.
Exactly.
So where you are referring, you have to tell them this is the aim why we want to start.
So Rajiv, let me ask you another question which a lot of people have, is that we've started them on phenofibrates. How much time will it take for the lipid in the retina to reduce how long the treatment should be. Patient said कि मेरा metabolic control तो ठीक है सर, पर ये पीले दाग क्यों नहीं जा रहे आंख से?
नहीं, पीले दाग फिनोफिब्रेट से नहीं जाएंगे. What he said, statin से जाएंगे.
नहीं, तो
See,
वो
to
ले रहा
reduce
है
the-
वो
yeah, yeah.
statin
No,
ले रहा
statin
है.
लेगा.
How much time?
See,
I think 6 to 12 months is the
12
minimum
months
time.
is the, yeah, you don't expect magic, but it will definitely take
Yeah.
time. But their statins are needed. So it's important you differentiate which are the patients you want to start on fenofibrate and which are the ones you want to start on statins. So if your aim is to reduce these exudates, statins are good. If you're trying for a long-term reduction in the grade of retinopathy, even prevention of laser, macular laser, or PRP, which Accord and your phenofibrate fibrate study both told, there is role of fibrates. So early stage of retinopathy without macular edema, without PDR, there is a role for phenofibrate. Presence of exudates, hard exudates, there is a role of statin.
Right. I just wanted this particular message to go back in the webinar. We can go on to the next presentation. Thank you.
Yeah, just one point. Just
Yeah,
one point
sure,
for
yeah.
the first case.
Yeah.
Any diabetic macular edema, if you see a disproportionate neurosensory detachment, see little bit NSD small is there, it's fine. But if you see a large NSD like his first case, definitely look for systemic factors. And it is not usually the HbA1c. The culprit usually is blood pressure or, as you rightly said, renal disease or anemia. So I think look for those parameters to control if you see this disproportionate NSD. In his first case, the neurosensory the retina was not actually that much swollen. It was the NSD which was
NSD
there.
which was there. True,
yeah, so you need to look for these.
So
Yes,
we will
definitely.
not have time. In the end, I had some rapid fire session. We had a case which came to us with massive edema with neurosensory detachment, underwent dialysis after 8 months, did not receive a single anti-VEGF injection and
It'll be flat.
So that's just corroborating what Raman's telling.
Correct.
So I would share one very interesting thing about NSD.
Yeah.
So I had at least 2-3 patients who were found to be anemic. Like the moment I used to see large NSD, anemia was associated. And I got this thing that definitely it is only anemia. So I started predicting. The moment I'll see a large NSD, I'll say isko to anemia hai. And 2-3 times it actually worked.
Okay.
And I was totally convinced this is the way. Then I did a study and anemia was not there. It is BP, which is more important. So it's important. Many times what we observe, we think that this is the truth. So when you properly do a study and then try to prove it, I was pretty sure anemia would be the strongest risk factor for neurosensory detachment.
Rajiv,
Yeah.
the hypertension would very often be renal.
Yes.
And the anemia is also renal. So
Renal.
there could be a concomitant thing
Renal.
in many of your patients.
Correct.
And
in this study, we excluded
was no
nephropathy.
yes, so
We
if you
excluded
then
nephropathy.
once you exclude nephropathy, the anemia will no longer be relevant.
Yeah, I agree with
So
you.
we go on to the
where my
next.
initial thing was coming through.
We go on to the next presentation. Dr. S.P. Chaudhary. Dr. S.P. is we know him personally as S.P. So I'll be calling you like that. S.P. is a very senior ophthalmologist, a senior vitreoretina surgeon. He is a product of Mananzar Medical College. Did his MS from GNEC, followed by a fellowship at Shankar Mitrale. He runs this complete eye care center and is a pillar at Delhi Retina Forum. SP is very active and prominent vitreoretina surgeon. Thank you for joining Noida Ophthalmic Society. SP, thanks a lot. And we welcome you and off with your presentation. Thank you.
Thank you very much, sir, for introducing me in such a way. Let me start sharing the script. The screen is visible?
Yeah.
So I think we have already discussed diabetic retinopathy in a great extent. And I will start my presentation with the role of anti-VEGF for PDR. Although, sir, you asked for a few cases. So my cases are going to be simple clinical pictures and management. So I feel that clinical examination and decision making is very important, and especially in diabetic cases. And we can do amazing a lot of things, but if decision making is wrong, then we burned our fingers. So not going in detail, the VEGF plays a major role in PDR. And we all know that it's a microvascular disease, and relative ischemia produces a pro-angiogenic environment, and which is largely played by VEGF. And studies have shown that, yes, there are high levels of VEGF in vitreous and fibrovascular tissues in PDR cases compared to normal eyes. PRP has been the gold standards, and definitely it causes regression of NV within 3 months. And according to DRS, this was the gold standard for last 4 to 5 decades. So starting with the first case, I think there's a simple case of PDR. We can see neovascularization of disc, neovascularization elsewhere. You can see extensive capillary non-perfusion areas. Patient was having mild diabetic macular edema, vision was 6.9, a good vision. So this is a clear-cut case, although you can see clinically, now as we discussed in between, that clinical examination is very important. Sometimes you don't need an angiography. This area over here, you can see that supratemporally there's an early fibrovascular changes, which you can see that in future patient is going to have fibrovascular changes, in particular this area. So the patient was planned for PRP 3 sittings and good diabetic control, and anti-VEGF were planned if the DME worsens. But doing the PRP, it has got many limitations. Patient has to be cooperative, need to have a clear media. It causes permanent visual loss in the periphery, and the chances of macular edema as per the protocol as study, and the other risk of having a choroidal neovascularization secondary to laser or loss of mydriasis and loss of accommodation. Case 2 is a case of a 45-year-old male, history of 20 years of diabetes mellitus, presented with 6/60 vision. You can see the florid-looking posterior fold, extensive neovascularization, which is going along the arcades through the nasal area. All of the disc is occupied with that. And on OCT, there was a neurosensitive detachment and some spongy retinal edema. So this is a classical case which will fit for a combination therapy of anti-VEGF with PRP. Now, if there was a fibrovascular component in this, probably those could have worsened. Also, this patient did very well, and at 4 weeks, you can see the regression of neovascularization around the disc and the supratemporal arcade, infratemporal arcade, and the macular edema also responded very well. This is another case. Now, what are we going to do about this case? Now, this is what I was talking about, the decision making. This is a 55-year-old male who presented with sudden drop in vision for last 15 days. Extensive subhyaloid hemorrhage, this neovascularization, plus NVD you can see over here, and diabetes are uncontrolled. Now there are 2 plans in this. We can have either we're planning for if we're not planning for like anti-VEGFs, like if we talk about the pre-anti-VEGF era, probably we'll do a PRP 3 sittings to regress the NV and then plan a PPV, because you take up such patients, there are very high chances that you'll burn your fingers. But now we have anti-VEGF, so anti-VEGF followed by the past-line vitrectomy can give a good outcome in such cases. I'm not going to show the videos or anything. So this is about the case presentation and the clinical decision making. This is another case. This is 60-year-old male. This patient I treated almost 5-6 years back. In fact, I discussed this at one platform also. So he was having diabetes mellitus, which are uncontrolled, having UTI, which was again resistant to antibiotics. So there are a lot of factors for this. The patient presented to me after 2 days after the cataract surgery. The cataract surgery was done elsewhere, and this was the fundus picture. You can see the fibrovascular fronts over here along the arcades. This ring-like structure was there. On OCT, you can see the neurosensitive detachment. But are you going to touch this patient 2 days after the cataract surgery? So either we have an aggressive approach or a conservative approach. So scared of like doing laser will worsen or not? Should I go for vitrectomy? Doing a vitrectomy is going to bleed, or patient going to lose the vision further. So we did a PRP for this patient, but unfortunately, as expected, after the PRP, the TRD worsened. I had to take up the patient for surgery. So past-line vitrectomy was done, membrane peeling, endolaser, and SOI. Of course, the membranes were not very simple to take away. So Now we look for the left eye. Meanwhile, the patient was having advanced cataract in his left eye. We waited for this UTI to get controlled and then taken up this patient. So learning from the right eye, I decided, okay, no, I'll go for the vitrectomy in this eye first go only. So I did the vitrectomy. Unfortunately, this after putting the macula was settled, but again he had a recurrence. I had to do the surgery second time, and then he's managing with this eye only. So these are the learning experience from the different patient. Each diabetic patient is different. So with this, can we say that this anti-VEGFs are very useful in this condition? Of course, yes, they are very useful. They inhibit the vascular proliferation, and they even can improve the vision in PDR cases. Is it a replacement of PRP? Let's see. I'm not going to go into the details of the trials. I think Sir has very well described about this. So these trials of RISE, RIDE, and VIVID and VISTA, which compared ranibizumab and aflibercept for DME, and also the protocol T, where they compare all the three anti-VEGF therapies. So the main outcome was that they definitely promote the regression of diabetic retinopathy. And like Sir, the Dinesh was discussing in between that the aflibercept is better. The study showed the initial phase, yes, it was better. The results were better, but at like later on, the results were almost the same for all the three drugs. Now we have studies for PDR also, like that was the DME studies, and it clearly shows that the anti-VEGF, if we compare the Clarity and TRCR protocol S, these anti-VEGF molecules are non-inferior as far as the visual outcome is concerned. And they like these patients who received anti-VEGF will have less development of DME and less progression of the PDR. And one of the very important thing we always think that we do PRP and we are basically destroying the visual field. So we are able to preserve the visual field also in these patients. And the PRP treated eyes were required more vitrectomy as compared to the anti-VEGF treated eyes. The results are more or less similar. So anti-VEGFs are very good, but they are not devoid of any side effects. So one of the most important side effects, as I showed this case also, the contraction of fibrous tissue, extreme fluctuations during the intraocular injection can lead to traction in the vitreoretinal traction. And this anti-VEGF itself promotes a switch from angiogenesis to fibrosis. And this is the reason we have to be very scared of anti-VEGF when you're using the PDR cases specifically. And one of the study has shown that incidence of 18% over a period of 2 days to 30 days after anti-VEGF injections. These are other things which has been reported, macular ischemia, macular hole, endophthalmitis. So it has limitations. We don't know how long we have to give, when we have to discontinue. And we should be aware about this, that this will definitely come back. The neovascularization is not going to go away with the anti-VEGFs alone. And protocol T and S clearly showed that approximately 30% of eyes with retinopathy will continue to worsen and risk of TRD. Another important factor is the financial burden. PRP costs us 1,000 to 3,500 per sitting, but anti-VEGFs have a higher cost, and we don't know how many injections we have to give. So these are the indications. As I discussed in my cases, PDR with DME, PDR with vitreous hemorrhage when it's difficult to perform the PRP, failed PRP, PDR with the NVG cases, and perioperative. As a vitreoretinal surgeon, I think we all know that these are one of the most complicated surgeries, and anti-VEGFs have changed the way we are doing the diabetic surgery. They facilitate in easier diabetic vitrectomy, less intraoperative bleeding, less endotherapy needed, shorter duration of surgery, less iatrogenic breaks, and hence the improved best corrected visual acuity post-op, and less need for use of oil, and less post-operative vitreous hemorrhage secondary surgeries. So with this, the take-home message will be that PRP still remains the definite treatment of PDR. We should not think that we can just get away with this anti-VEGFs alone. They can be used as adjunct to PRP, and they have role, as I told earlier, in media opacity, dense cataract, non-clearing vitreous hemorrhage. And pre-treatment of anti-VEGF agents before vitrectomy for complicated PDR is very useful. And in last, the least, this judicious approach and thorough clinical examination is must when we're using anti-VEGF in PDR. Thank you.
Thanks, SP. Thank you for a very exhaustive presentation. Any comments, Dr. Dinesh?
Ajay, I wanted to ask all the retina surgeons why they are not, they are concerned only about the anatomical studies on the retina, but nobody is interested in electrophysiology What are the electrophysiological changes in diabetic retinopathy? I will ask all the retina surgeons.
So there is, I believe this is that the electrophysiology. Does anybody else wants to answer? Dinesh? Rajiv, I think Rajiv has done electrophysiology a lot on diabetic retinopathy recently with the
Yeah, you'd like to take it, then I can add something.
No. I have
You are
gone
telling.
through it, and I've gone through it, and we have discussed together. But I
Yeah.
would like you to comment about it.
One of the thing is it is more like a research tool, but now we have couple of devices which are skin electrodes and which you can do it a little more quickly in clinical practice. It gives mainly the inner retinal damage, and which does happen in diabetic retinopathy. However, clinically, like people are now even trying to look at post anti-VEGF response correlating with it, but not very strong evidence as far as so people look into the flicker ERGs rather than looking at a full field. A flicker, which may be a fixed luminance or a multi-luminance flicker, is something which is more relevant as far as response after anti-VEGF is concerned, which is of more clinical importance. Academic importance is PHNR and the other pattern ERGs telling about the inner retina. But again, not more as far as clinical, how your decision making will change. I don't think anything much is there.
I think that last statement sums it up. The reason why, as a clinician, I'm not bothered about electrophysiology is because it's giving it's giving me a global response without telling me anything that will help me in treatment. So what's the point? Supposing, let's say the amplitude is affected. Let's say the latency is affected. Let's say everything is affected. So what? If the patient's vision is 6.9, I still don't care. And if the vision is 660, I want to know why is it 660. I am not interested in the electrophysiology because it does not change the management of the patient. If it was going to change the management of the patient, I would definitely be interested. So that is the reason why the stress has not come. Where the stress comes in, maybe in terms of anterior ischemic optic neuropathy. You do want to know. Previously, in terms of CRVO also, we were bothered about ischemic versus non-ischemic because it made a difference in our response time. But now I don't have to bother about that. Anyway, I'm going to treat it with the anti-VEGF agents, and I am going to cover with the lasers when I see the CNP areas. So again, no longer is there any role for electrophysiology. So even though it looks very nice to say, I do electrophysiology. Yeah, okay, I may do electrophysiology. What do I get out of electrophysiology? That's the issue. And the other important thing is,
that's what people are now trying to look at. Can it be as an endpoint for giving injections?
Yes.
So people are exploring that, and that's what I was telling. People are more looking into flicker ERGs, the fixed luminance and multi-luminance, where you reduce the luminance and then see. But again, these are all evidence is still generating. We really don't know.
The thing is, by the time it starts giving you better evidence than the fact that the size of those cavities is now stable, and which is what you use right now. So it has to give you something beyond that.
Yes.
Otherwise, it's not of any value to me.
And tomorrow Rajiv will correlate the fundus photograph with ERG and give you better picture by AI.
Yes, maybe. Absolutely true. When you have multiple of these information, then maybe we really don't know. Things may change because it can predict probably about progression of the disease. Having more ischemia, converting from moderate severe to PDR, those information may be combined multimodal along with functional imaging may give some better.
So when you can tell about the heart status and sex from the fundus photograph, then why not other things?
Yes.
Another thing that it may give you, if you have multifocal ERG, maybe you can correlate the areas with different kind of lesions to different kind of responses. So you can figure out which lesions are more deleterious for the visual function as compared to others. But at the moment, these are research tools.
What do you feel, Dr. Goel?
No, what I feel is that first thing is that we should know that the electrophysiology, ERG, flash ERG is only giving you the global retinal function. Now, if you are using pattern ERG, if there is a diabetic macular edema, then the macular function is given by the pattern ERG or multifocal ERG, because the multifocal ERG is giving you the flash response or global response of the retinal ganglion cells in the central retina, while the pattern ERG, it will give you the there are two waves. One is positive wave, P50 wave, which is giving you the macular photoreceptor function, and the N95 wave is giving you the ganglion cell function. Now, if there is any macular lesion, so you should do pattern ERG so as to find out what is the extent of damage in the retina, because this is a true picture of the functional damage in the retina. Anatomical damage can be found out by the OCT, but the electrophysiology will never tell lie. So whatever the function is there, so it is reflected by the electrophysiology. Supposingly in diabetic retinopathy, non-proliferative diabetic retinopathy, if you are doing oscillatory potential, you are doing pattern ERG, or you are doing flicker fusion frequency, 30 Hz flicker. So these will give you the potential which is left and the amount of damage which has already been done. In patients of non-proliferative diabetic retinopathy, moderate to moderate retinopathy, if you are taking 10 patients or 20 patients of moderate diabetic retinopathy, in case a patient is having poor as oscillatory potential or poor pattern ERG as compared to the brother patient or sister patient, so the patients who have poor electrophysiology with the similar otherwise findings, so these are the patients who are destined to develop a proliferative diabetic retinopathy in future. So these are the patients who need closer observation as compared to those who have the normal electrophysiological findings on pattern ERG or multifocal ERG, okay, or oscillatory potential. So that is what we were, whenever you are trying to take a study forward, the electrophysiology also should be a part of the investigating team. Yes. Because you are not only studying the structural part, you are studying the functional part also, and you have to prognosticate the patient also. So electrophysiology is the tool by which you can prognosticate the case as well. If you are doing a study for hundreds of patients or thousands of patients, then only you can collimate the data, and then you can predict, you can tell also that this is the prognosis.
Thank you, sir. I think
Dr. Goyal, that was wonderful.
Yeah.
You know, the problem that comes up with electrophysiology, one is that the repeatability is not so good, and very few people are able to do it in a manner that the machines are standardized and repeatable. That's one problem. The second thing is, even something which is simpler, like for ganglion cell function, the simpler method of testing would be to do contrast sensitivity. But even that we do not do, because it requires very intensive, conditions, very stringent conditions for lighting. Even a difference in lighting changes the contrast. So contrast sensitivity can't be you just can't just put it in any room. Whereas contrast sensitivity is probably a more sensitive and easier method of evaluating ganglion cell function than an ERG. So that way, the functions are there, the tests are there. The thing is how to make it within the time availability. I mean, जो मेरा routine clinical work है तो मैं खत्म नहीं कर रहा हूँ, तो मैं क्या उसमें contrast sensitivity भी add करूँगा और electrophysiology भी add करूँगा. So then that is why it gets left to the clinical research teams. Unless the teams find out a way of finding either a huge amount of information from that, or finding out easy ways of doing that. Like, for example, Rajiv was talking about skin electrodes. So yes, supposing you find a way that in 5 minutes में तुम करके मेरे को भेज दोगे और वो repeatable है.
Yeah, that's what it is happening now. So like exactly what you said here, the same is even with contrast. Yes. We've been working with Dr. Robson, the Pillay Robson.
Yeah.
Out of them, the Robson, we have been working with him. And he has developed now like a Amsler chart, small tear-offs, contrast charts, which you can do it with. You don't need a specific lighting or anything. So what you are telling exactly is coming into play. Like people are trying to make these tools which can be used in the clinical practice more often. Maybe ERG machine. That's what the dialysis company is trying to make it more clinically acceptable one. Likewise, contrast also, there are multiple of these charts which are coming now. This is with the Precision Vision company. So definitely what you're telling will come into in next few years. We'll be using it more often, these tests which were supposed to be a research tool.
So anyway, I think the line of thought is correct. We have to have electrophysiology and contrast sensitivity included in our systems. Once these systems become cheaper, more easy to use.
उससे पहले ना near vision करना शुरू कर दो. I mean, you're talking of diabetic macular edema.
True, very true.
All your studies talk about distant vision. Actually, near vision is
more important.
More important.
Correct.
If the near vision of a patient is affected, even if his distant vision is okay, please treat the patient.
Okay, so just one thing, thanks SP. I wanted to ask all of you one question from SP's talk was how much important is the crunch phenomenon in PDF cases of giving an intravitreal injection? Do you really give too much importance to it? And when do you say, okay, I will not inject now? You know, you have a PDR with a vitreous hemorrhage, you do not know how much traction is there, or you give an injection and you are ready that within a few days I'm going to operate. Any comments? Rajiv, Shahana, Anubhav, please.
Sir, I will say only those cases where you see clear-cut surface NVEs without any fibrous membrane, without any papillous disc involving traction. With the, only in such cases we can plan one injection, see the response after a month, can plan PRP. But in patients who are having a dense vitreomacular traction, already a fibrous band, dense obscuring vitreous hemorrhage, either we should not inject, we should go ahead with targeted PRP slowly, or we have to keep in our mind that we need to go for surgery once we inject in such cases.
Rajiv, I'd like to ask you, in continuation with Ajay's question, if you have a patient with some degree of fibrous neovascularization, so fibrovascular neovascularization raised above the surface, say going along the arcade, would you take up this patient for anti-VEGF therapy as a, as your treatment of choice, along or without PRP?
See, in these cases, the use of anti-VEGF would be only when you are thinking of treating the DME component. Just for PDR, definitely no. And even when you are planning for DME, as you said, it all depends on whether your traction is threatening the fovea or not. If there is a prolif which is beyond your arcades, you can still go ahead giving injections. But if it is something like what you said, just near the arcades, it is threatening, I will tend to avoid. I'll tend to avoid. So these are not the cases, right cases. There, the increase of traction is definitely there. Risk of, you would have probably waited for doing a vitrectomy next 2-3 years and you will be landing up in a vitreous surgery early. So definitely don't inject anti-VEGF in these eyes.
I think that's the important message. The when it's raised posteriorly near the arcades,
avoid.
Find an alternative.
Right. Thank you. Thanks. Thanks, Rajiv. Thanks. Anybody else?
So, frankly speaking, sir, like what I said in the talk, now a lot of people, in fact, in the beginning, I have noticed few referrals I got, the people were injecting a vitreous hemorrhage only. But if you go by the studies and by our personal experience when we are treating the patients, the only two indications are like Rajiv sir said, association with DME and when we are planning for a surgery. Even we have any extensive neovascularization, they do respond very well to PRP and metabolic control also. But just for the sake of regressing the NV, there is no point injecting the anti-VEGF until we are planning for surgery.
Thank you, SP. We go on to the next presentation. I know we are a little delayed, more delayed. Shahana is angry on that. But anyway, we're having a good discussion. So introducing Dr. Ankur Bhatnagar, who has joined us at Vision Plus Eye Center. Welcome, Ankur. Ankur is a comprehensive ophthalmologist and has done his medical retina training He recently joined us. I'm encouraging him to present. So here, Ankur will be presenting on role of steroids in DME. Welcome, Ankur. Please share your screen.
Good evening, sir. Thank you for introducing me. Good evening, seniors and all the participants. So, am I audible?
Yeah, you're audible, but you have to share your presentation. You've shared your email screen.
So you need to change the screen.
My screen is sharing.
You need to change your screen.
Please change the screen. Can you stop share, sir, first?
Stop share.
Now first open the presentation, then do the share.
Open the presentation and then share.
Now it is visible?
No, your yeah, correct. It's visible. Okay, go ahead.
So good evening, everyone. This is Dr. Ankur. So my topic is about use of steroids in DME. So first of all, anti-VEGF have been our main and first line treatment in all the phakic eyes. And steroids are having a specific indications, mainly in pseudophakics. They can be given in a periocular, intravitreal, and suprachoroidal route. So first, before going to the cases, we can just have a gist on in what cases we can use steroids and they can be useful. So any case which is resistant to the anti-VEGF, any non-center involving DME with plaque of hard exudate, but normal foveal contour, macular edema with significant extrafoveal traction in early pregnancy because anti-VEGF can lead to preeclampsia and abortion, and DME and pseudophakic patients in center involving DME with grade 3 ischemic changes on FFA because steroids are known to increase the retinal perfusion and vitrectomized eyes, a non-compliant patient because they have decreased frequency in steroids in chronic DME and in all in which the cardiovascular complications are there, which um, tells us not to use the anti-VEGF. So these are a few OCT biomarkers which helps us to decide our course. So hyperfluorescent and diffuse DME and foveal hyperautofluorescence on fundus photos, HRS or hyperreflective spots, which are 30 microns, less than 30 micron size. They are located both in inner and outer retina. If they are similar to nerve fiber layer, and actually they represent the aggregates of microglial cells. So, and DME with cystoid changes, neurosensory detachment, we already talked about it, increased thickness of the inner retina or disorientation of the inner retina. So, coming to the case, so this case one is a 60-year-old female who came to us in Jan 2020 with blurred vision. She was diabetic since 5 years and hypertensive since 2 years. And looking at her two eyes, BCVA was 612 in the right eye and 612 in the left eye. She had moderate cortical cataract in both eyes. Her fundus picture is shown there. She has a hard exudate, a patch of hard exudate in both the eyes with some dot plot hemorrhage, giving a moderate NPDR pictures. Her metabolic control was fine with HbA1c 6.8 and urine microglobin 19. So first we went ahead with anti-VEGF centrics in both the eyes in February, September, and October. So after February, her next visit was on August because of the COVID lockdown. There was lots of follow-up. So what was interesting to see that in the left eye she was stable. She had initially she had cystotic spaces in both the eyes when she came in January in the OCT. But after the injection, after the long follow-up, also her left eye was stable, but her right eye seems to have this large cystoid space, which was worrying us. If we go for the more elaborate picture in the right eye, what was happening was after we gave 3 injections in January, then after her follow-up in September and also in October, but that large steroid space remained there in August. It was there with 612 vision. She dropped, and it was also there in September, and October also. And then in November, we decided to go for. We thought we labeled it as a refractory edema, and we went for this Ozurdex injection. We There was some advancement in cataract also, and we were planning for her cataract surgery also. So we went for the Ozurdex injection in November, and after 1 month of the injection, she had this. Uh, in the December, she had this her edema settled down, and vision was 6/9 partial. After 2 months, we decided for the anti-VEGF followed by cataract in both the eyes. So this was her last OCT. She has in March 2021, after her surgery followed by injection. She has stable edema in both the eyes. She still had this right cystic spaces in the right eye, and IRF in the left eye. But she was quite happy with her vision. She was 6/6 in both eyes, and we told her to have a good metabolic control. So, and we told her to observe. Uh, we, uh, so it's need to be thought ki what can be if we can re-inject her, or it need to be observed. So she was quite happy in the last. Take home with this case was ki DME cystoid species responded well to Ozurdex. Her cataract surgery was responded well also, because it was in the cover of Ozurdex, and two eyes can have different response to anti-VEGF. Uh, so this case 2 was a obese female. She was pseudophakic in both eyes with lasered PDR with CMA in both eyes. And she was on anti-glaucoma medications. Her IOP was well under control, but the cupping was 0.7. She has received a series of anti-VEGF in both the eyes together with Ozurdex. So this was the OCT pictures. They showed complete uh, large cystoid spaces in both eyes, complete disorganization of the inner retinal layer, and NSD2. So we went ahead with the injection, suprachoroidal triamcinolone injection, both the eyes. This OCT comparing her post 10th day after suprachoroidal injection, and the 34th day. After 70 days, her vision increased from 636 to 618. After and This is the third case. This is a 60-year-old female. She was diabetic and hypertensive since 19 years, and she was also laser PDR with CME case with the adherent ERM. So with the adherent ERM, she has uh, large cystoid spaces, subfoveal and parafoveally. So she has received 3 injection of anti-VEGF and 2 Ozurdex injection before implants before, and left eye was stable NPDR, but the right eye we still went for. We were thinking what course to take, but we went for this suprachoroidal triamcinolone injection again, and she improved again from 636 620. The edema also got settled, and cystic spaces reduced. After we lost her to after 11th day post triamcinolone, we lost her to follow up. So what in center we give intraocular steroids options as triamcinolone intravitreal triamcinolone, Ozurdex implant, and suprachoroidal injection, and most patients do respond to suprachoroidal injections. In the case 2, in which the glaucoma, the patient glaucomatous eye was there, this suprachoroidal injection has been quite safer in those patients, and all the patients in which we have given suprachoroidal injections, they have not gone intravitreal, and the IOP has been well under control. So we should judicially, the steroids in the DME should be judicially used. We have to see the phakic status of the eye, and uh, uh, her glaucomatous status also, her IOP is under control. And when given judicially and at the right moment, taking all the factors into consideration, the results have been quite encouraging. Thank you.
Thank you, Ankur. I think since paucity of time, if can you unshare?
Yes, sir.
So paucity of time, I think it's difficult to have a discussion on this until somebody has a specific question. So should we go ahead with Priyanka's presentation, because we need to finish off. Anybody has any questions? So thank you, Ankur. We'll thank you for your presentation. You have brought up the value of steroids and the different routes. We'll go on to Dr. Priyanka Khandelwal, who is a consultant vitreoretina surgeon at IK Hospital. She has been trained in Kolkata, and she was with me for some time in Delhi Retina Center, so I know her personally. And Priyanka is a very ambitious and very proactive girl who wants to do a lot of things. And thank you for becoming a member of NOS. You'll be presenting on many occasions, so please go ahead with the presentation.
Thank you so much, sir, for such a warm welcome, and thank you for giving me the opportunity. Is it
Please share. Yeah, no, your screen is not visible. Can you please share?
Yes.
You have to share your presentation. Open your presentation on.
Is it visible now?
Yeah, it's visible. You can put it on the presentation mode. Correct.
I will be presenting some of the cases for differentiating pseudophakic CME from diabetic macular edema in the setting of diabetic retinopathy patients. Because of the short of time, I will be running directly to the cases. This was the first case, who was 66 years old diabetic gentleman presented in our OPD for second opinion for retina with complaints of decreased vision in left eye after uncomplicated cataract surgery, which was done 3 weeks back. He was advised injection bevacizumab elsewhere for the left eye diabetic macular edema. On examination, his visual acuity was 6/6 N6 in right eye and 6/9 N6 in left eye. Anterior segment was within normal limits with right eye NS2 cataract and left eye pseudophakia. Fundus examination revealed both eye moderate NPDR with left eye CME. We did the OCT, and OCT showed clear cystic spaces in outer plexiform and outer nuclear layer with some degree of subretinal fluid. With the clinical evaluation and OCT based on it, we consider it as a pseudophakic CME, and the patient was again started on steroids with NSAIDs and was asked to come back after 3 weeks. But patient came back after 1 week with the further loss of vision, and patient was 6/9 part this time, and vision was 6 and 8 for the near vision. And when we examined the patient, that patient had the cystic spaces were more, and OCT showed there was an increase in the central macular thickness, which was marginal, but yes, there was an increase in the cystic spaces. So we decided to go for angiography. In angiography, there was early pooling of dye into the foveal avascular zone. And in middle phases, we can see there is a capillary leak with the microaneurysms. In the later middle phases, there was a capillary leak, but microaneurysms were not leaking. And there was a pooling of dye in the foveal avascular zone, which intensified into the later phases. And there was a mild disc staining also. There was a characteristic patelloid appearance into the fovea. So we decided to stick to our diagnosis of pseudophakic macular edema, and patient was injected with posterior subtenon injection of tricot. This was the case 2, which was also a diabetic gentleman who came with decreased vision in his right eye since cataract surgery, which was done 6 months back. He was diagnosed as pseudophakic CME, and injection posterior subtenon tricot was given 2 months back. His right eye vision was 612 N8 and left eye 69 N6. Both eye had pseudophakia, and on fundus examination, there was mild NPDR with CME in the right eye. So we go for OCT. In OCT, there were clear cystic spaces, but at this time there was involvement of all the retinal layers, including the inner retinal layers. Here the ganglion cell layer is also involved. And in parafoveal area, we could make out some hyperreflective dots. So we did angiography. In angiography, we found in the early phases, there were some microaneurysms at the foveal edge, which were leaking in the later phases. So in this case, we made a diagnosis of diabetic macular edema, and we injected with the injection eccentrics, and this was the follow-up OCT after 1 month. So it is important to distinguish pseudophakic CME from DME, as one can be treated conservatively and other needs intravitreal injection in the form of either anti-VEGFs or steroids. These are some of the points which helps in differentiating pseudophakic CME from DME. Pseudophakic CME had clear cystoid spaces, whereas DME can have clear or some hyperreflectivity into the cystoid spaces, which can be spongy or both kind of cystic spaces. Inner nuclear layer, outer plexiform layer, and outer nuclear layer cysts are more common in pseudophakic CME, whereas outer nuclear layer cyst involvement is there in DME. Cysts are spreading into the centrally located into the pseudophakic CME, and their cysts can be parafoveal also into the diabetic macular edema. SRF is usually present in pseudophakic CME, whereas SRF is not that common into the DME. There is a relatively lesser incidence of subretinal fluid. Presence of hard exudates, hyperreflective dots are common, and involvement of ganglion cell layer and retinal nerve fiber layer cyst strongly favors diabetic macular edema. FFA is considered as gold standard for diagnosis. Disc staining and petalite pattern into the fovea are diagnostic. Whereas in diabetic macular edema, microaneurysms will be leaking and disc staining will be absent. So take-home message is FFA is required to distinguish PCME from DCME in the setting of DR, and ideally blood sugar levels and diabetic retinopathy, if there is any, should be under fair control before taking patient for surgery. Thank you.
Thanks, Priyanka. I think that was very brief and crisp, and I think it's very important to differentiate pseudophakic CME from diabetic macular edema, especially in patients who have been operated for cataract, where we probably did not know the macular status, supposing he had a mature cataract, and subsequently patient develops this. So we should be able to differentiate. Any comments, Dinesh?
No, I think it's a good observation, and it's worth keeping in mind that you don't have to be very aggressive with anti-VEGF agents. If you have a post-operative patient who's got some macular edema, at least first give him a chance with NSAIDs, and then only later on consider starting an anti-VEGF agent. And if you have a doubt, you can, as you said, you can do a fluorescein angiography, and that will help you to make a diagnosis much easier than any other methods. So good job.
Yeah, so we have had a wonderful discussion. Before I close, I would like that we run a small video, which is of Bayer. Before I thank, so I would like, please stay back for another few minutes. I know it's getting late. Everybody is getting delayed, but to run this programs, we need support. So let me just quickly do this. I just play it. Is it visible?
Yes.
Hi, Ritesh.
At Bayer, the year 2020 started off with a commitment to help thousands of WAD, PCV, DME patients in India as we introduced the ILEA for You pilot program in February 2020, involving 60 centers. We plan to further extend this program to centers across the country within the year based on the response and feasibility of our pilot program. However, the progress came to a grinding halt as the world was hit with the devastating effects of COVID-19. The widespread effects of this virus caused the country to stand still, hampering our expansion plans for ILEA for You program. The unprecedented times came with its challenges, but we took it in our stride and endeavored to overcome the challenges and emerge successful in delivering our program. Approximately 3,000 plus doses were given to over 1,800 enrolled patients, with more than 50% patients returning for the third to fifth injection. Overwhelmed by the positive response and patient compliance, we just couldn't wait any longer to introduce ILEA for You program in centers across the country. We are proud to announce that thousands of WAMD, PCV, DME patients can now benefit from this program as we make ILEA more affordable. With this vision in mind, we are providing 5 injections at the cost of 2 injections to help patients get affordable treatment in these testing times. So effective price to the patients will be less than 23,000 rupees per injection, which is lesser than some of the available anti-VEGFs. We welcome you all to ILEA for You program.
Hello. Bayer is committed to address unmet needs in our innovative products and research is helping it globally reduce weight. In India too, with the launch of ILEA, we made available best-in-class treatment, Retinopathy as well as DME. And also the programs of ILEA for You, which we launched last year, is intended to increase access as well as adherence for better outcomes across millions of patients.
Hello and namaskar. As you are aware that we started ILEA for You somewhere in the first quarter, and we received a very strong response. This ILEA program, we were able to in fact, we could excellent feedback and our commitment to the patients had motivated us to further expand this program. I'm very happy and announce that we are expanding this program across India, all centers. We sincerely very successful so that more and more patients can get
So thank you all very much. I must thank our speaker, Dr. Rajiv, who took out so much time and was there with us for all this while. Would thank Dr. Dinesh Talwar that despite being so busy, in fact, he cancelled part of his OPD to be with us in this program. Thank you, Dinesh. Thank you, Shahana, for helping me designing this program. And thank you, Professor Goel, for always being with us to help us and encourage Noida Ophthalmic Society. I think our programs, this was our 6th meeting. We have become very active, and I am really happy that all of you who presented the cases Ruchir, SP, Priyanka, Anubhav, Ankur, you have. It's been really very good that you have participated so well, and must thank Bayer in the end for helping us with this program. We look forward to more such programs, and I'm sorry for being late. I think we carried over the discussion a little too much, but sometimes this discussion, I think it was valuable. I think I learned a lot personally.
Yes, I learned a lot. It was a very good discussion. Nicely organized meeting.
Thank you, Rajiv. Thank you, Rajiv. And
Thank you, Dr. Ajay.
Thank you, Ajay. And
Thank you, Ajay.
Thank you, sir.
Yeah, and I thank Dr. Ajay for giving a dose of steroids to the NOS meetings, I think.
And I look forward, Shahana, to the UVA program. So I'll be pounding you with phone calls within few days. Okay.
Bye-bye.
Thank you.
Thank
Bye-bye.
you.
Thanks a lot. Bye,
Thank you.
everyone. Thanks a lot. Thank you.
Bye.